The subcommittee will come to order, and the chair recognizes himself for an opening statement. Thank you all for being here. In today's markup, we will consider 17 bills that advance the goal of protecting and promoting greater patient access to quality care, making our health care system more transparent for patients and their families, and driving more competition and choice in our healthcare system. These bills represent key priorities of the American people, and I look forward to advancing these bills. Our shared bipartisan goal has resulted in productive bipartisan discussions leading up to this markup. Many of the bills we are considering are the product of robust bipartisan work with the common goal of helping patients. The subcommittee undertook a rigorous process. We held hearings. We heard from impacted stakeholders, including relevant government agencies, and we incorporated feedback shared with subcommittee members and staff from both sides of the aisle over the course of the past several weeks. We made improvements to ensure these proposals ultimately have the greatest impact on patients. I'm proud of the work we have accomplished to get us to this point. These bills represent key priorities of the American people, and I look forward to advancing these bills before us to the full committee. We have heard countless stories about how the complexity and opacity of the healthcare system and how that impacts patients, employers, and even healthcare providers. Today, we will consider legislation to increase transparency into the prices that hospitals, laboratories, and insurance companies charge patients and employers. The legislation would also increase transparency in the prescription drug market and the vertical integration that has taken place in our healthcare system. These solutions will bring much needed transparency to patients and employers. As policymakers, we are strengthening our healthcare system and federal programs to ensure patients are getting the greatest value. The legislation before us today also reauthorized numerous programs designed to bolster patient access to care, particularly for those most in need. We're taking up legislation to protect access to care in vulnerable communities by eliminating looming cuts to disproportionate share hospitals and continuing funding for the Community Health Center program, both of which serve thousands of patients in each of our districts. One of the problems that I hear about most frequently back home are the workforce challenges across the healthcare system. Legislation before us today would serve as one step to addressing some of these challenges, especially in rural communities, by extending funding for the Community Health Center Fund, the Teaching Health Center's Graduate Medical Education Program, and the National Healthcare Service Corps. We're also promoting access to care for vulnerable Americans who need life-saving, one-of-a-kind treatments. My bill, the Medicaid Value-Based Agreements for Patients Act, or the MVP Act, will provide access to the most innovative cures for Medicaid patients living with otherwise incurable or untreatable life-threatening conditions. We're talking about patients dealing with diseases such as sickle cell, Duchenne muscular dystrophy, and debilitating bleeding disorders. I want to personally thank Representative Eshoo for her leadership to take on this bill with me that will ultimately save lives and promote long-term savings for state Medicaid programs. Our hearings have shown us how lower costs and higher quality of care can be achieved through policies that promote competition and choice. One of these policies will ensure seniors aren't paying more for drugs depending on where the drug is administered. Seniors shouldn't pay more for the same drug and same level of care in one setting than another, and this policy is a first step towards broader reform. Additionally, patients waiting for a transplant have suffered from lack of competition within the organ procurement transplant network. These critically ill patients shouldn't be left waiting longer for a life-saving transplant because of an outdated system, and today we'll vote on legislation to increase competition and improve the effectiveness of this critical service for some of our most vulnerable patients. In closing, I want to express my gratitude for my colleagues on both sides of the aisle for how deeply engaged everyone has been on these issues. I'd also like to thank the staff of the committee and our offices, member offices on both sides of the aisle who have worked tirelessly to get us to this point. The American people and our healthcare system will ultimately benefit from our bipartisan work and the leadership of everyone in this subcommittee. I appreciate everybody's help. I yield back and recognize the ranking member for 5 minutes for an opening statement.
Thank you, Mr. Chairman, and good morning, colleagues. Today we're marking up 17 bills. 17 bills, that's a lot of bills. That's a lot of work products, right? Yes. 11 of which will be included in one package to increase transparency in healthcare strengthen critical public health programs, and secure access to care for low-income Americans. First, we're marking up legislation to reauthorize the animal user fee programs and overhaul and modernize the nation's organ transplant system. That is a huge issue, and bravo to the entire committee, all of the members on that, because this is something that's really needed. Talk about life or death situations. Next, we're considering a comprehensive package of bills that advance bipartisan efforts to reauthorize and expand vital public health programs, increase transparency for hospitals, health plans, and PBMs, long time in coming, including my bill, the PBM Accountability Act, to reveal the business practices of pharmacy benefit managers that drive up prices for patients, prevent cuts to Medicaid, disproportionate share hospital payments, and bring down the costs of health care to pay for the provisions of the bill. Something else that's really very important. I'm pleased we're also marking up 2666, the MVP Act legislation that I'm really pleased to have joined the chairman on to codify a CMS rule that ensures that Medicaid enrollees have access to breakthrough gene therapies to treat and cure diseases such as sickle cell anemia and cystic fibrosis. We've worked hard to tailor this legislation to align it more closely with the underlying rule and give CMS the adequate flexibility to update the provision in the future. We're also marking up legislation to establish patient protections on highly rebated drugs and to require HHS to issue an annual report to Congress on how changes in Medicare payment systems impact provider and payer consolidation. The last bill is H.R. 3290. That increases reporting requirements to participants in the 340 drug pricing program. I have some serious concerns about what I view as cherry-picked metrics in this legislation that, in my view, don't accurately represent the program or its benefits, and I plan to vote against it. This markup is a culmination of months of work by subcommittee members to examine some of the most pressing issues in health and to develop solutions, policy solutions that address what needs to be addressed. I'm so proud of members of the committee, both sides of the aisle, and thank you for your leadership, Mr. Chairman. I urge all of us to continue these bipartisan conversations. Most frankly, it makes me look forward to coming to work because I have great hope that the work is going to really end up in movement. So with that, I yield back.
Thank you. Thank you for your kind words, and the gentlelady yields back. The chair now recognizes the chair of the full committee, Chair Rodgers, for 5 minutes for an opening statement.
Good morning. Thank you, Mr. Chairman. And yes, to my colleagues, 17 bills, good things happening, continuing to happen in the Energy and Commerce Committee. I'm proud of this committee and the work that we're doing, building on the rich bipartisan history to come together on important priorities for the American people. The legislation we are considering today will help lower costs for Americans and provide more health care price transparency, responsibly fund community health centers and diabetes research, prevent harmful cuts to hospitals that serve the most vulnerable patients, train more doctors in our communities, and improve FDA's review of animal drugs used by farmers and pet owners. We're taking action on the American people's priorities to make the healthcare system more affordable and patient-friendly. We all know that healthcare is too expensive, and the system is far too complicated. And well-intentioned government policies have too often provided more benefits to large and well-resourced corporations than they have patients. Take the story of Mike Laus from Maine. Last year, he spent 1 hour in an OR undergoing eye surgery. His bill included 3 separate facility fees, totaling $7,800 and the professional fees totaling $6,200. Why are 3 facility fees necessary for 1 hour of surgery in the OR? I don't know. But I do know that the system must be simpler, more affordable, and work better for patients. That is why we're moving bills today to increase price transparency and competition throughout the healthcare system. I want to thank Ranking Member Pallone for his partnership on our bill, the Transparent Price Act, which builds on the work that's been done by both the Trump and Biden administrations to bring prices to patients. We've had 2 hearings on price transparency and lowering health costs. I know they've spurred additional ideas on how to help patients, and I look forward to taking a first step on that work today and continuing this work moving forward. There's another critical reason this markup is so important. The American people want accountability in our government. Congress cannot meaningfully fulfill its critical oversight and spending roles without examining the reauthorizations of expiring programs through regular order. We have heard from HRSA on the importance of these programs and worked hard to make sure the additional mandatory spending is fully offset. I am proud that we're extending mandatory funding for the Teaching Health Center GME program for 6 years. This will help as they plan and recruit for future residency classes. Extending mandatory funding for the Community Health Center Fund will help ensure health centers in my district and yours have adequate resources to provide much-needed primary care services in the community. Finally, regarding ADUFA, whether or not you know it, almost everyone in the room relies on animal drugs approved by the FDA. Whether you have a pet, drink milk, eat meat, the FDA plays a very important role in making sure the drugs we give animals work and are safe. It is important we get this work done on time and in a bipartisan way. So I'm glad that we're on track to reauthorize this on time by moving Representative Pence's legislation through subcommittee today. I look forward to the discussion as we prepare for full committee markup. The Energy and Commerce Committee continues to plow the hard ground necessary to legislate on some of the most important issues before us as a nation. And I certainly appreciate everyone's support, making sure that we are giving people, providing the care, the health care that people need at a price that they can afford. Thank you, everyone. I yield back.
Thank you. The chair yields back. The chair now recognizes the gentleman from New Jersey, Representative Pallone, the ranking member, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Today, the Energy and Commerce Committee is doing what we do best, and that's finding a bipartisan path forward to make healthcare more affordable for the American people. I want to thank Chair Rodgers for all the work we have done together to get to this point on the comprehensive H.R. 3281, the Transparent Price Act. While it's not the exact bill I would have written, it represents a good compromise. Our bipartisan legislation will improve the transparency of our healthcare system, lower costs for patients, and strengthen our healthcare workforce by reauthorizing important programs that make care accessible in the most high-need communities. The Transparent Price Act does exactly that. It brings more transparency to the healthcare system. It requires both hospitals and insurers to make price information public for all to see, and requires the information to be displayed in a standardized format so it's easier for consumers to understand. Access to accurate prices for healthcare services empowers both employers and consumers to compare prices so they can save money on healthcare services. Bringing more transparency to the healthcare system also encourages competition, which can also help reduce healthcare costs. I'm pleased we're considering 2 bills that will increase transparency into the practices of pharmacy benefit managers, or PBMs. PBM contracts are opaque, making it difficult for employers and plan sponsors to understand drivers of cost so they can negotiate lower costs. The PBM Accountability Act, introduced by Representatives Custer and Carter, will help employers and consumers better understand drug price information in an effort to help lower healthcare costs. We're also marking up bipartisan legislation to help ensure that state Medicaid programs are not overpaying for prescription drugs. This will help ensure that scarce Medicaid dollars are going towards patients, not PBM profits. The subcommittee will also consider H.R. 3262, led by Representatives Schakowsky and Bilirakis. This bipartisan legislation will require hospitals and physician practices to disclose ownership data, including for entities owned by private equity firms and venture capital firms. Studies show that health consolidation is leading to higher healthcare prices. This bill will help increase transparency of hospital ownership and provide greater insight into hospital and provider consolidation. We'll also mark up 2 bills that will reduce costs for Medicare beneficiaries. The first bill, led by Representative Sarbanes and Joyce, would ensure hospital outpatient departments are billing appropriately under the Medicare program. And the second bill would align payment for the administration of drugs in hospital outpatient departments with the physician fee schedule rate. Right now, Medicare pays substantially more for low-complexity services delivered in hospital outpatient departments compared to a physician's office. And this has contributed to increased hospital consolidation, shifted care to higher cost settings, and increased cost sharing for seniors. Importantly, we will reinvest the savings to cancel the impending cuts to payments for Medicaid disproportionate share hospital, or DSH, for 2 years. Hospitals that serve a large number of Medicaid and uninsured patients are a crucial part of the healthcare safety net, and the legislation before us today will help these providers by canceling the $16 billion of DSH cuts scheduled over the next 2 years. I'm also pleased that the package includes a 6-year reauthorization of the Teaching Health Center Graduate Medical Education Program and doubles its current funding over those 6 years. This program moves primary care training into the community. It allows teaching health centers to address the workforce shortages in underserved areas and increase access to primary care. The legislation provides much-needed security for the program so that it can recruit talented doctors and bring new centers to underserved communities. While I look forward to advancing all of these bills, unfortunately, there are 2 bills I cannot support. I oppose H.R. 3290 because it would obscure the value of the 340B program, which helps covered entities stretch federal dollars to help more patients. I also oppose H.R. 2666, which would make permanent a Trump-era regulation that experts have said could increase the cost of prescription drugs to state Medicaid programs and the federal government. But despite my concerns with these two bills, I'm proud of the bipartisan work we're doing today. And with that, Mr. Chairman, I yield back the balance of my time.
The gentleman yields back. The chair reminds members that pursuant to the committee rules, all members' opening statements will be made part of the record. Are there further opening statements? Representative Burgess from Texas, you're recognized for 3 minutes for opening statement.
Thank you, and I think we got a good list of bills under the committee's consideration for markup today. There are bills that encourage price transparency, so anything that we can do that lowers the cost and improves the complexity of our healthcare system is good for patients. I want to thank Representative Clark, Representative DeGette, and Representative Crenshaw for working with me on the Supporting Safety Net Hospitals Act, which would postpone the DSH cuts for 2 years. I wish we could have a complete repeal. This committee did provide that language 5 years ago, and ultimately it wasn't successful, but this is important to at least delay for the next 2 years. I hope we can continue discussions on how to move forward in future hearings. Earlier this week, I introduced H.R. 3284, the Compete Act, which would require the Secretary to consider within the annual rulemaking process the effect of regulatory changes to certain Medicare payment systems on provider and payer consolidation. Regulators should understand the full effect of vertical and horizontal consolidation amongst both providers and payers. With this information, then we can be better informed on how payment rules affect price, quality, and access to care. Lastly, I want to speak on a bill that wasn't included. I hope at some point we can, but as many of you know, I've been concerned about the regulation that prevents doctors from being able to own hospitals or that prevents doctor-owned hospitals from expanding. Look, my dad was a doctor. He built a physician-owned hospital that served the patients in his community for years. It is a very personal issue to me. Our former colleague, the late Sam Johnson, on the Ways and Means Committee carried this bill for a long time. He was never quite able to get it across the finish line, but I hope moving forward we can revisit the possibility of including the difficulty of physicians not being able to own hospitals in a future markup. And thank you, Mr. Chairman. I'll yield back.
The gentleman yields back. Anyone seeking recognition for an opening statement? Seeing no other members seeking recognition for an opening statement, the chair we'll move to hearing the bills and marking up the bills. So the chair calls up H.R. 1418, and ask the clerk to report.
H.R. 1418, a bill to amend the Federal Food, Drug, and Cosmetic Act to reauthorize user fee programs
Without
relating to...
objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? What purpose does the gentleman from Indiana seek recognition?
Move to strike the last word.
The gentleman is recognized for 5 minutes, so strike the last word.
Thank you, Chairman Guthrie and Ranking Member Eshoo, for holding this hearing. I'm proud to champion the fifth reauthorization of the Animal Drug User Fee Act with my colleague, Congresswoman Schreier. This important legislation is critical to ensuring safe and effective drugs for our nation's livestock industry and farm animals for the next 5 years. Farmers, ranchers, and rural communities across southern Indiana rely on veterinary medicines and therapeutics produced by animal drug manufacturers. Innovators in the Hoosier state, like Elanco Animal Health, are leading the charge to keep America's farm animals safe and healthy. The fees associated with this legislation is collaborative investment between the FDA and America's animal health companies. In addition to providing the FDA with resources to expedite reviews and approvals, our legislation would ensure the agency is transparent and held accountable for performance goals. This legislation would preserve the security of our nation's food supply by making certain the medications administered to the food-producing animals are safe for animal and human health. I look forward to working with my colleagues on the Energy and Commerce Committee to get this legislation across the finish line. With that,
Will the gentleman yield?
I
Gentleman
yield.
Thank you, gentlemen, for yielding. Both the animal drug user fee agreements and animal generic drug user fee agreements before us today will enhance our ability to keep our household pets and farming animals healthy while continuing to promote human health in the process. Specifically, the AGDUFA before us today includes improved transparency requirements for FDA that will help sponsors more effectively work with regulators to address outstanding issues with new generic drug applications. It also includes a commitment from the FDA to take action on 90% of these applications within 100 days of submission. The AGDUFA agreement for us to consider today will allow the agency to collect $174 million in fees from the industry from 2024 to 2028 while making critical program enhancements designed to streamline the review process for both regulators and industry. Urge my colleagues to vote yes on H.R. 1418, which is must-pass legislation. I also would like to thank the lead sponsors, Representative Spence, Representative Dr. Schreier, for their work over the past several months to write legislation that is broadly supported by members on both sides of the aisle and relevant stakeholder groups. I also commend their thoroughness in building up broad support for the legislation before us. Now yield back to my friend from Indiana.
I yield back.
You want your own time, right? You want your own time. So what purpose does the lady from Washington seek recognition?
Mr. Chairman, I move to strike the last word.
The gentlelady is recognized for 5 minutes to strike the last word.
Thank you, Mr. Chairman, and thank you, Representative Pence, who I'm very glad to work with on this bipartisan legislation. This bill will allow the FDA, through its Center for Veterinary Medicine, to approve necessary drugs and medications for companion animals and livestock. It will accelerate the development of animal therapeutics and promote a more predictable and streamlined review process. It'll hold the FDA accountable to performance goals that will enhance inspection times and provide some regulatory certainty for investors and innovators and pet owners alike. And it will preserve the security of our nation's food supply by ensuring that the medications administered to food-producing animals are safe for human and animal health. Animal safety is important for all of us. If you have a sick pet, you trust your veterinarian to help, and your veterinarian relies on the FDA to ensure that the medications he or she is using are safe for those pets. AGDUFA ensures these medications get to market. In my district, farmers, ranchers, dairymen also rely on these FDA-approved medications to keep their livestock healthy. For them, keeping their animals healthy is not just about their affection and responsibility for those animals. It's an economic issue. It is critical for food production and food safety and their economic survival. So having timely access to affordable, effective medications is a key part of our domestic food chain. I'm also happy to see that this markup builds on the last ADUFA's reauthorization in terms of monitoring and addressing antibiotic resistance or antimicrobial resistance to ensure that our antibiotics stay effective. 5 years ago, the Center for Veterinary Medicine committed to a number of activities and surveillance and monitoring of antibiotics to make sure that we're using these medications correctly. Interventions such as judicious use of antibiotics, which happens in human and veterinary medicine, are intended to limit antimicrobial resistance and keep these drugs useful and to keep animals healthy. The progress report this year gave us insights into FDA's goals and activities regarding antibiotic resistance and how far they've come, from publishing lists to education on this topic. There's still more to do, and as a physician, I understand the importance of these drugs, the extreme danger posed by antibiotic resistance, and look forward to working with the FDA to ensure good stewardship of and on antibiotics. So thank you again, Representative Pence. Delighted to work with you, and I encourage all my colleagues to vote yes on this important legislation. I yield back.
The gentlelady yields back. Is anyone seeking recognition on the underlying bill? Seeing none, are there bipartisan amendments to the bill? The gentleman from Indiana is recognized for his amendment.
Mr. Chairman, I have an amendment at the desk.
The clerk will report.
Amendment in the nature of a substitute to H.R. 1418, offered by Mr. Pence. Strike all after the enacting clause and insert the following. Section 1.
Without
short
objection, the first reading of the amendment is dispensed with, and the bill will be open for dispensed with. And the gentleman is recognized for 5 minutes to speak on the amendment.
Thank you, Mr. Chairman. I'm pleased to offer a manager's amendment that would add technical changes to further support animal and human health. This amendment builds on the agreements contained in H.R. 1418 and reflects additional bipartisan work on the reauthorization of ADUFA and AGDUFA. It includes provisions to ensure greater transparency and accountability within FDA's Center of Veterinary Medicine through new reporting requirements on face-to-face meetings and activities the center is undertaking to support the development and stewardship over antimicrobials. The amendment before us today would also support usage of the conditional approval pathway for animal drugs, a pathway that brings more medicines to the market to treat unmet clinical needs. And it would be done by amending the major species definition to reflect changing animal populations. And with that, Mr. Chair, I yield back.
The gentleman yields back. Anyone seeking recognition for discussion of the amendment? Gentlelady from California seeking recognition for discussion of the amendment.
I have an amendment at the desk to the amendment.
I believe we have to move on this amendment, then you'll be recognized for it.
It's an amendment
To the aims, okay. The gentlelady is recognized for her amendment.
Thank you. Mr. Chairman,
Clerk, wait, I'm sorry, I have to have the clerk report. Will the clerk report the gentlelady from California's amendment?
Amendment to the amendment in the nature of a substitute to H.R. 1418, offered by Ms. Badagan. Add at the end.
Without objection, the reading of the amendment is dispensed with. No objection, so ordered. The gentlelady is recognized for her amendment.
Thank you, Mr. Chairman. Mr. Chairman, I'm offering this amendment, which I intend to withdraw, with the hope that I can get your support to work on this issue ahead of the full committee markup. This committee is always focused on innovation, and my amendment would work to support innovation, animal feeds that can be used to promote human and animal health. My amendment would clarify FDA's authorities and expectations for new zootechnical animal food substances. It responds to the demands of pet owners, farmers, and veterinarians to promote animal welfare and food safety. These categories of animal food substances have the potential to reduce pathogens in animals intended for human consumption, support animal health by improving their microbiome, and reduce waste emitted by animals. For example, feeding a cow seaweed-based food products have been shown to reduce the amount of methane produced by the cow, and many veterinarians on farms choose to do this already. Under current law, however, companies must go through the lengthy drug application process to make claims about these effects on product labeling. This has kept many products off the shelves, limiting access to farmers and other animal owners. In fact, the FDA spoke in support of this amendment at a recent hearing, because they recognize the potential for innovation in this area. It also has the support of the farmers and leaders in the agricultural industry, including the National Milk Producers Federation, innovators in the animal food industry, including the National Grain and Feed Association, and environmental organizations, including the Environmental Defense Fund. My amendment will cut through red tape. It's a pro-business, pro-agriculture, pro-animal, and pro-environment. It's a win-win for all involved. Unfortunately, we were not able to find agreement with the majority ahead of the subcommittee markup, but it is my hope that we will not turn our backs on an opportunity to support animal health and scientific innovation. Mr. Chairman and colleagues across the aisle, I intend to continue working on this issue ahead of our full committee markup, and I hope to offer it again with the support of the members of the majority. I encourage my colleagues across the aisle to work with me in advancing this policy. With that, Mr. Chairman, unless any of my colleagues would like time to speak on it, I will withdraw my amendment.
Thank you. Well, we're going to speak on the amendment first. Anyone on Mr. Johnson, you're recognized for 5 minutes to speak on the amendment.
Well, thank you, Mr. Chairman, but now that she has withdrawn the amendment, I'm fine.
So now the gentlelady from Washington is recognized for 5 minutes to speak on the amendment.
Thank you, Mr. Chairman. I would just like to echo Ms. Barragan's comments about food additives and the need to expedite their review and inclusion. This is something that is important. It is important for animal health, also important for climate solutions, and as she mentioned, seaweed additives and other additives can be critical for reducing methane emissions. So I am also hopeful that this will be included in the final markup and look forward to working on this. I'll note that the Farm Bureau is supportive. Thank you. I yield back.
The gentlelady yields back. Is there any further discussion on the amendment to the Ains? The Barragan amendment, seeing none, the amendment is withdrawn. Is there any further discussion on the amendment by the gentleman from Indiana, the Ains? Seeing none, if there's no further discussion, the vote occurs on the amendment. So we're voting on the Ains offered by the gentleman from Indiana. All those in favor shall signify by saying aye. Aye. All opposed, nay. The ayes have it, and the amendment is agreed to. Does anyone seek further recognition to speak on the bill as amended? Seeing none, the question now occurs on for an H.R. 1418 as amended to the full committee. All those in favor will say aye. All those opposed will no. We'll have a roll call vote. All those in favor will vote by saying aye. All those no. The clerk will call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Mr. Burgess. Mr. Burgess votes aye. Mr. Latta. Mr. Latta votes aye. Mr. Griffith. Mr. Griffith votes aye. Mr. Bilirakis. Mr. Bilirakis votes aye. Mr. Johnson. Mr. Johnson votes aye. Mr. Bouchon. Mr. Bouchon votes aye. Mr. Hudson.
Aye.
Mr. Hudson votes aye. Mr. Carter. Mr. Carter votes aye. Mr. Dunn. Mr. Pence. Mr. Pence votes aye. Mr. Crenshaw. Mr. Joyce. Ms. Harshbarger. Ms. Harshbarger votes aye. Ms. Miller-Meeks. Ms. Miller-Meeks votes aye. Mr. Obernolte. Mr. Obernolte votes aye. Chair Rodgers. Chair Rodgers votes aye. Ms. Eshoo. Ms. Eshoo votes aye. Mr. Sarbanes. Mr. Sarbanes votes aye. Mr. Cardenas. Mr. Cardenas votes aye. Mr. Ruiz. Mr. Ruiz votes aye. Ms. Dingle. Ms. Custer. Ms. Custer votes aye. Ms. Kelly.
Aye.
Ms. Kelly votes aye. Ms. Barragan. Ms. Barragan votes aye. Ms. Blunt-Rochester. Ms. Blunt-Rochester votes aye. Ms. Craig. Ms. Craig votes aye. Ms. Schreier. Ms. Schreier votes aye. Mr. Hand. Mr. Hand votes aye. Mr.
How's Ms.
Vaughn.
Dingle recorded?
Ms. Dingle is not recorded. Ms. Dingle votes aye.
How is Dunn recorded?
Mr. Dunn is not recorded. Mr. Dunn votes aye. Mr. Joyce is not recorded. Joyce votes aye.
Anyone else seeking to enter the roll call? Anyone on your side, I guess?
Mr. Pallone.
Call my name. I vote aye.
Mr. Pallone votes aye.
Anyone else seeking recognition of vote? The clerk shall report.
Chair Guthrie, on that vote, we have 29 ayes and 0 nays.
With 29 yeas and 0 nays, the bill as amended is agreed to. The chair calls up H.R. 2544 and asks the clerk to report.
H.R. 2544, a bill to improve the organ procurement and transplantation network and for other purposes.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek to be recognized on the bill?
Mr. Chairman,
What purpose does the gentleman from Indiana seek recognition?
I move to strike the last word to speak on the bill.
Dr. Shawn, you is recognized for 5 minutes. Dr. Bouchon for 5 minutes for strike the last word.
Thank you, Mr. Chairman. The Securing the U.S. Organ Procurement and Transplant Network Act, or H.R. 2544, which I introduced with my colleague Robin Kelly, seeks to improve our national organ procurement and transplantation network, or OPTN, program, which is overseen by HRSA and run through a contract with the United Network for Organ Sharing, or UNOS. According to increasing numbers of reports, the OPTN struggles to obtain and distribute organs in an efficient, timely, and appropriate manner. In fact, it is believed that thousands of donated organs go to waste each year because the process of obtaining organs, matching them to a recipient, and transporting them is not happening effectively. With the technology and expertise we have today, this is totally unacceptable. H.R. 2544 allows HRSA to improve the OPTN program. It clarifies that HRSA does not have to implement a single contract for all aspects of the program and encourages a competitive process to choose the best contractors for each OPTN function. As a physician in Congress, my focus with this legislation is on ensuring that HRSA has the authority that it needs to act on behalf of patients and ensure the best innovators are able to compete and play their part in saving lives. I yield back.
The gentleman yields back. Anyone, what's the purpose of the lady from Illinois seek recognition?
I'd like to strike the last word.
Gentlelady's recognized. 5 minutes to strike the last word.
Thank you, Chair Guthrie and Ranking Member Eshoo, for holding this bipartisan markup and including H.R. 2544, the Securing U.S. Organ Procurement and Transplantation Network Act, that I was so proud to co-lead with the Vice Chair of the Health Subcommittee, Dr. Bouchon. Around 6,000 Americans die each year while waiting for organ transplants, with the problem being even more acute for people of color and people in rural communities. Black people are 4 times more likely to develop kidney failure than white people, but they are much less likely to receive a life-saving kidney transplant. Additionally, Black people also experience the highest rates of health failure but receive heart transplants at lower rates than their white counterparts. These are tragic inequities that are unacceptable. That is why I was glad to see HRSA's leadership last month announcing the Organ Procurement Transplant Network Modernization Initiative. As our country continues to move forward at a rapid pace, with new technologies becoming available every day, we owe it to our constituents to bring our medical practices into the 21st century and save lives. The Securing the U.S. Organ Procurement and Transplantation Network Act will provide HRSA with greater ability and resources to improve the OPTN program. It clarifies that HRSA does not have to implement a single contract for all aspects of the program and encourages a competitive process to choose the best contractors for each OPTN function. This bill complements HRSA's recently announced goal of modernizing the network, and I encourage my colleagues to support this bill. Thank you, and I yield back.
Gentlelady yields back. Anyone else seeking recognition on the bill? Seeing none, are there any bipartisan amendments to the bill? Seeing none, are there any other amendments to the bill? Seeing none, the question now occurs on forwarding H.R. 2544 to the full committee. All those, roll call, we'll have a roll call vote. All those in favor will vote aye. Those who vote no, the clerk will call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Mr. Burgess. Mr. Burgess votes aye. Mr. Latta. Mr. Latta votes aye. Mr. Griffith. Mr. Griffith votes aye. Mr. Bilirakis. Mr. Bilirakis votes aye. Mr. Johnson. Aye. Mr. Johnson votes aye. Mr. Bouchon. Aye. Mr. Bouchon votes aye. Mr. Hudson.
Aye.
Mr. Hudson votes aye. Mr. Carter. Mr. Carter votes aye. Mr. Dunn. Mr. Pence. Mr. Pence votes aye. Mr. Crenshaw. Mr. Joyce. Mr. Joyce votes aye. Ms. Harshbarger. Ms. Harshbarger votes aye. Ms. Miller-Meeks. Ms. Miller-Meeks votes aye. Mr. Obernolte. Mr. Obernolte votes aye. Chair Rodgers. Chair Rodgers votes aye. Ms. Eshoo. Ms. Eshoo votes aye. Mr. Sarbanes. Mr. Sarbanes votes aye. Mr. Cardenas. Mr. Cardenas votes aye. Mr. Ruiz. Ms. Dingle. Ms. Custer. Ms. Custer votes aye. Ms. Kelly. Ms. Kelly votes aye. Ms. Bodegon. Ms. Bodegon votes aye. Ms. Blunt-Rochester. Ms. Blunt-Rochester votes aye. Ms. Craig. Ms. Craig votes aye. Ms. Schreier. Ms. Schreier votes aye. Ms. Strahan. Ms. Strahan. Mr. Hand votes aye. Mr. Pallone. Mr. Pallone votes aye.
Anyone seeking recognition? How's Mr. Dunn recorded?
Mr. Dunn is not recorded. Mr. Dunn votes aye.
Anyone else seeking recognition for? How's Mr. Cardenas recorded?
Mr. Cardenas is reported as aye.
Have anybody else coming? Anyone else on our side? The clerk shall report.
Chair Guthrie, on that vote, we have 27 ayes and 0 nays.
With 27 ayes and 0 nays, I haven't called the vote yet. So how's Mrs. Dingle recorded?
Ms. Dingle is not recorded. Ms. Dingle votes aye.
Nick of time. Seeing no one else, thank you. Thanks for your effort. Seeing no one else, I'm going to have 28 yeas and 0 nays. The bill is agreed to. The chair calls up H.R. 2691 and asks the clerk to report. Oh, excuse me, no, I'm sorry, I'm out of order on this. The chair will call up H.R. 3281. Oh. Oh, that's wrong. Okay, 3281. The chair will call up 3281
H.R.
and ask the clerk to
3281,
report.
a bill to promote hospital and ensure price transparency, being enacted by the Senate and House of Representatives of the United States of America and Congress assembled. Section 1, short.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any time so ordered. Does anyone seek to be recognized on the bill? For our purposes, the gentlelady from Washington seek the chair from Washington seek recognition.
Mr. Chairman, I have an amendment at the desk. It's marked Health Mark SC01.
The clerk shall report the amendment.
Amendment in the nature of a substitute to H.R. 3281, offered by Ms. Rodgers. Strike all after the enacting clause and insert the following. Section
Without
1.
objection, the reading of the amendment is dispensed with. So ordered. The gentlelady is recognized for 5 minutes to speak on her amendment.
Thank you, Mr. Chairman. This amendment, in the nature of a substitute, would take dramatic steps to improve transparency in our healthcare system, responsibly fund critical programs, and lower costs for patients. It includes at least 11 bipartisan proposals, and I want to thank each and every member who's worked on these for their leadership. I also want to thank Ranking Member Frank Pallone for his steadfast partnership on this legislation, the Transparent Price Act, which codifies and improves upon regulations to increase price transparency in our healthcare system. But the bill now goes much further. It includes legislation from Representatives Joyce and Sarbanes to increase accountability and transparency into billing, to ensure off-campus hospital outpatient departments are paid at the correct rate. A bill from Representatives Miller Meeks and DeGette would further improve upon price transparency by ensuring patients can shop for the same lab test they can shop for at hospitals and at other laboratories. A critically needed proposal from Representatives Custer, Carter, Eshoo, and Guthrie that would increase transparency into the prices PBMs pay to help employers and employees save money on their medicines. Two proposals that would dramatically increase transparency into healthcare consolidation. One from Representatives Shirkowski and Bilirakis that would increase transparency into changes in ownership among Medicare providers, and one from Representatives Harshberger, Schreier, Bilirakis, and Shirkowski that would provide critical information on the effects of vertical consolidation. Or in other words, providing an answer to the question of what happens when an insurance company owns physicians, pharmacies, and pharmacy benefit managers, and what does that mean for patients and taxpayers? It also includes funding for vital public health programs, including legislation led by Representatives Joyce, Stefanik, Blunt, Rochester, and Fletcher that increases funding for community health centers and the National Health Service Corps and extends the programs for 2 years. A proposal to extend the Teaching Health Center GME program for 6 years while incrementally increasing its funding. Legislation led by Representatives DeGette and Bilirakis that would increase funding for the Special Diabetes Program and extend it through fiscal year 25, and legislation led by Representative Cole and Ruiz to increase funding for and extend the Special Diabetes Program for Indians for 2 years. The amendment averts $16 billion in reduced federal Medicaid payments to safety net hospitals. The amendment addresses generic drug applications that include quantitative differences in an ingredient and would require FDA to provide directional guidance on sameness to generic sponsors. It includes a proposal that will save seniors money by ensuring that they do not pay more for drugs that are administered in a hospital outpatient department than they would for drugs administered in a doctor's office. And finally, the amendment bans spread pricing in the Medicaid program. I urge all of my colleagues to support this amendment, and I yield back.
The gentlelady yields back. Anyone seeking recognition on the amendment? The gentleman from New Jersey is recognized for 5 minutes. We're going to go to Anna first.
You want to go first?
I'm sorry, Anna. The lady from California is recognized for 5 minutes.
Thank you very much.
Mr. Chairman. I want to thank Representatives Pallone and McMorris Rodgers for introducing this amendment to rein in wherever, however best we can address and rein in abuse and waste in our healthcare system and improve health outcomes. I'm pleased that it includes the bill that I've co-led, the PBM Accountability Act, which requires PBMs to provide annual reports on drug costs, rebates, and patient utilization to plan sponsors and the GAO. This information will strengthen our insights into the drug supply chain and allow sponsors to address business practices that increase drug costs. It will also save the federal government over $2 billion over the next 10 years. But transparency is just the first step, I think, in a broader effort to address the enormous profits that PBMs are extracting at the cost of patients. I stand ready to consider additional legislation to counter consolidation and perverse financial incentives in the PBM industry, including removing the link between high-cost drugs and payments to PBMs. The AINS also reauthorizes and increases funding for 5 public health programs that expire on September 30th. The community health centers will receive a 5% increase in funding, and the National Service Corps and the Special Diabetes Program will each receive a 13% increase in funding to continue providing care and conducting research that improves the health of vulnerable communities. Importantly, the amendment will extend the Teaching Health Center's graduate medical education program for 6 years and double the funding for the program by 2029. I'm thrilled that we found a bipartisan agreement on this program reauthorization. The steady funding stream will create new training sites for primary care physicians, which we are desperate for in our country, and allow the program to reach its full potential. I'm also really pleased that about the inclusion of a vital provision to delay cuts to DISH relative to DISH payments to ensure that these essential hospitals can continue serving low-income and uninsured patients. These provisions are all paid for by reforms to our healthcare system, including a bill to prohibit spread pricing for payment arrangements with PBMs under Medicaid, and a bill to increase the speed of generic drug entry. Another pay-for will align all Medicare payments for drug administration services with the physician fee schedule over the next 4 years. The savings generated by these reforms are being reinvested back into programs that have been proven to expand access to high-quality health care. So I'm obviously fully supportive of this amendment. Urge colleagues to vote for it and yield back.
The gentlelady yields back. I'll recognize myself to speak on the amendment. This amendment would take the necessary steps to permanently empower patients with pricing information on healthcare services before they receive care. The Transparent Price Act would also help employers make more informed decisions about the healthcare benefits they are purchasing for their employees and drive better deals that can lead to lower costs and greater value. Specifically, this legislation would codify and improve upon the Trump administration's hospital price transparency rule, as well as the transparency and coverage rule, both of which President Biden continued after taking office. We have heard repeatedly over the past several weeks about the importance of price transparency and its potential to unleash meaningful market-driven changes to our healthcare system. In one such case, a witness who testified before the committee used price transparency to drive down costs for her state's financially distressed employee healthcare plan, bringing its reserves into surplus within a few years. This is just one example of the benefits of exposing the true prices of healthcare. The Transparent Price Act is a very positive step towards ensuring that patients can shop for prices just like they do for other goods and services. The manager's amendment also provides greater transparency in how healthcare providers bill Medicare. It does this by implementing recommendations from the HHS Office of the Inspector General that would create a process to separately identify and confirm accurate billing by providers. The manager's amendment also includes a policy to help patients save on drug costs by requiring that the Medicare program and patients pay the same rate for physician-administered drugs in an off-campus hospital outpatient setting as they do in a physician's office. In addition, the manager's amendment wraps together so many important priorities. It would address workforce shortages by the continuing Teaching Health Center, National Health Center core programs, and continued support for vital community health centers. Further, it will avoid catastrophic cuts at disproportionate share hospitals set to take effect next year. Importantly, the manager's amendment does all this in a fiscally responsible way by fully offsetting the increases in mandatory spending. I thank the leaders of the full committee for their bipartisan work on this issue. I urge my colleagues to support the aims and vote yes. And I have 2.5 minutes if anybody wants, or I'll yield back and then you can have your own time, unless you want your own time. I'll yield to the gentleman from New Jersey.
California? Or John?
Oh, I thought New Jersey. Well, California. New Jersey first, then California if you have time. If not, I'll give you mine.
Thank you, Mr. Chairman. I move to strike the last word and speak on the amendment in the nature of a substitute. As I mentioned in my opening statement, the amendment in the nature of a substitute to the Transparent Price Act will improve transparency in our healthcare system and extend and increase funding for critical public health programs like community health centers, teaching health centers, the National Health Service Corps, and the Special Diabetes Program. Now, I know that both Ms. Eshoo and Chair Rodgers mentioned the increased funding and extension for these programs. But I do want to say how important that is, because I think many of you know that in the past, we've often faced possible expiration of these programs, and they're not being reauthorized in a timely fashion. So in all these cases, whether it's special diabetes, National Health Service, community health centers, teaching health centers, we're doing for at least 2 years with some increase, sometimes a significant increase in funding. But this is really important because, you know, if you use your community health centers as an example, they need to plan in advance. And if they don't know that these programs are reauthorized and that the money is available, and they can't plan and provide additional services, for example. So I really want to stress that. I'm proud of the work that we've done together and the funding increases we were able to give these programs that invest in the future of our healthcare system. Now, the AINS also includes a version of Representative Custer's legislation to reduce drug costs by bringing new generic competition to the market. When generic drug manufacturers bring applications for new generics to FDA, they must show the drugs are therapeutically equivalent to their brand counterparts with the same active ingredients, and must also show that the inactive ingredients are quantitatively and qualitatively the same. Under current law, generic drug sponsors must engage in a guessing game about these inactive ingredients, estimating the ingredients and their amounts, and wait for FDA's response to their application. The language in this AINS will reduce some of the burden from this guessing game. If a drug sponsor is off on an important inactive ingredient, FDA will be required to tell the generic sponsor which ingredients are off and whether they need to go higher or lower to match the brand drug. However, I am disappointed because we could be bringing new competition to the market even faster. The legislation introduced by Representative Custer, which passed this committee unanimously and received nearly 400 votes on the House floor last year, would require FDA not only to say whether the amount of the ingredient is higher or lower than the brand drug, but also by how much. This eliminates much of the back and forth between FDA and drug sponsors, cutting several months off the development time of a new generic drug. Under the language in this AINS, there could still be multiple rounds of correspondence, which means months of wait time at FDA as generic drug sponsors aim to get the ingredients exactly right. So with Representative Custer's original bill, we can cut through this red tape, bringing savings for consumers and the federal government. This would provide an opportunity for increased investment in community health centers and teaching health centers, or more research into diabetes programs. So all members of the committee voted for Representative Custer's stronger bill last year, and I don't think there's any good reason to reverse course now. So I would ask Chair Rodgers and Guthrie to work with me and Representative Custer and Ms. Eshoo on strengthening this provision before the full committee markup so we can bring more competition and save money. Now, lastly, I wanted to comment on a proposal in this amendment in the nature of a substitute that will reduce costs for Medicare beneficiaries by aligning payment for drug administration in hospital outpatient departments with the physician fee schedule rate. This proposal would require Medicare to pay outpatient hospital departments the same rate as the independent physician's office for administering the same intravenous or injected medications. This is a common sense piece of legislation. The drugs included for payment changes are routinely administered by physicians in the offices all around the country. They require no special equipment or backup capability that justifies the extra cost of hospital-based administration. The most frequently administered outpatient drugs, such as non-opioid pain medications and antibiotics, are all safe to administer in a physician's office. Immunizations and allergy shots are also frequently given in a freestanding physician's office and are far more expensive when given to a hospital-owned outpatient department. Now, I'm concerned that, well, let me say this. Many common and important medications that can be given in physician specialist offices are often provided in hospital-owned facilities. And I'm concerned this not only shifts care to higher cost settings, but also increases cost sharing for beneficiaries. So I'm very concerned that this has contributed to increased hospital consolidation and acquisition of independent physician practices. So this bill is a reasonable and important step forward in reducing beneficiary cost sharing for drug administration, and also ensures that Medicare dollars are used more wisely. So I urge my colleagues to support the proposal, and I yield back, Mr. Chair.
Jim will yield to me. I
Oh, yeah,
was gonna say,
sure.
we'll continue conversations on some of the issues that you have brought forward. So we'll continue before we get to full committee. So I'll yield back.
I appreciate that. Thank you.
Gentleman yields back. Anyone speaking in recognition? So next will be the gentleman from Florida, Mr. Villarakas, for 5 minutes.
Thank you, Mr. Chairman. I appreciate it. I move to strike the last word. I want to say this, good work, team. You guys did an outstanding job. Thank you, Mr. Chairman, and I thank the ranking member as well, and the ranking member on the subcommittee, and of course, the chairman of the full committee. So I want to express my strong support for the aims to H.R. 3281, the Transparent Price Act. This legislation pulls together the culmination of over a dozen bipartisan bills that begin to tackle true price transparency and address skyrocketing costs in our healthcare system. I want to thank again Chair Rodgers and Ranking Member Pallone for negotiating this deal, and of course, the chairman and the ranking member on the subcommittee. It includes fully offset federal healthcare workforce program extenders at increased funding levels, such as community health centers. I've been proud to lead the bipartisan legislation, the appropriation letters each year. And earlier, the last few years with others, but initially with Ranking Member Pallone, to ensure discretionary funding is provided to our community health centers, and I'm glad to support Dr. Joyce's efforts to reauthorize the Community Health Center Fund for the next 2 years. Community health centers, as everyone knows, plays an essential role across the U.S., including in my home state of Florida, where they are integrated into rural, suburban, and urban communities to provide vital primary care and referral resources. This package also includes legislation I've co-authored, H.R. 2550, with Representative DeGette, that will extend the special diabetes program for the next 2 years, as well as a bill from Representative Cole to extend the special diabetes for Indians program, both an increased funding rate of $170 million per year. These new investments in research will help maintain and spur on additional innovation in the search for new treatments and cures for type 1 diabetes. We are making great progress in this space with new FDA therapeutics coming to market that delay the onset of type 1 diabetes. Great progress. We can only imagine the future strides that will be made as a result of greater investments and sustained research funding at NIDDK. Additionally, this comprehensive package builds off the policies we examined in our legislative hearing 3 weeks ago to provide much-needed transparency and accountability in healthcare. This includes additional updates to better operationalize and simplify the price transparency rules at CMS so that it actually works for patients at the hospital and insurer level. It also requires off-campus hospital outpatient centers to attest to unique identification codes to ensure compliance with existing site-neutral laws and statute for Medicare. And it provides overdue accountability for PBMs to annually provide employers with transparent data on cost sharing and drug spending via rebates. Lastly, it includes legislation I lead with Representative Schakowsky, H.R. 3262, the Reporting on Ownership Information of Health Specified Entities Act. This will require hospitals, emergency centers, ambulatory surgical centers, insurance companies, provide equity firms, and others to report and disclose data, HHS, on ownership-related information, including on any changes in ownership and data on mergers and acquisitions. Our proposal will then require the agency to publicly report this ownership information and publish an analysis of trends in horizontal and vertical consolidation in the marketplace. Additional clarity into these trends will allow us to better understand anti-competitive practices in healthcare that may be driving up costs and find ways to combat these practices. I know I don't have much more time. All of these transparency initiatives are aimed at ensuring that employers and consumers are armed with the information they need to shop and understand where their dollars are going in the healthcare system. Ultimately, we must put patients at the front and center of this process rather than charged with bills and medical that they cannot afford. All right, I'll stop right there, Mr. Chairman, but it's a great amendment, and I appreciate the chairperson offering the amendment. Terrific bill. Let's get it done. Thank you, and I yield back.
Okay, the gentleman yields back. Anyone seeking recognition? Mr. Sarbanes? The gentleman, what purpose you seek recognition?
I move to strike the last word.
Gentleman from Maryland is recognized for 5 minutes.
Thanks, Mr. Chairman. The aims that we're looking at today is obviously a strong bipartisan package. Will ensure continued access to care for millions of Americans, bolster our healthcare workforce pipeline, help lower costs for patients by promoting transparency and accountability across healthcare system. I congratulate you and the ranking member and the committee for pulling this together. It includes a critical reauthorization, among other things, of our community health centers, which serve millions of Americans in every corner of the country, as well as support provision of primary mental and behavioral health services for children at school-based health centers, and that's an area of particular interest for me, so glad to see that. It also includes a critical extension and expansion in the National Health Service Corps, which in Baltimore, we've had some terrific examples of how that can work. That helps address the nation's current workforce shortages while better preparing a more diverse, well-trained workforce for future public health crises. Finally, I'm also proud that the amendment includes the text of a bipartisan bill that I joined Mr. Joyce in introducing to require providers to use a unique identifier for each provider-based site when they build a Medicare program. While this might not sound important, it will give CMS the tools it needs to ensure compliance with existing law, reducing overall costs to Medicare program. I used to do that previously in my previous life. Among the things I did was help healthcare providers get these particular unique identifiers, and you can track the dollars better that way. It's better for Medicare, it's better for patients, it's better for the practitioners. So very important remedy being addressed here. I urge my colleagues to support the amendment. I look forward to continuing to work in this bipartisan manner on these very critical healthcare issues, and I'll yield to Mr. Cardenas the balance of my time.
Thank you for yielding. Thank you, Chair Guthrie and Ranking Member Eshoo, for holding this markup. This shows that we all are very much aware of how increasing costs for healthcare are breaking the backs of Americans around the country, and I'm excited to see provisions in this amendment that would improve transparency, address the impacts of hospital consolidation on patient costs, invest in our public health infrastructure and healthcare workforce, and reduce the cost of medications. As I mentioned in previous hearings, we only achieve true transparency if we make every effort to ensure the information is presented in a way that is understandable for all. As we have learned, when it comes to hospital and insurance transparency rules, there are no explicit requirements to include non-English language in disclosures. This oversight can leave many non-English speaking people in America, like many in my district, without access to adequate pricing information. I'm thrilled to see the amendment in the nature of a substitute incorporate language ensuring accessibility for those with limited English proficiency. Specifically, it would require insurers and hospitals to ensure information is available, including through interpretation services or translations of such information. If we are serious about improving transparency for Americans and reducing costs for patients, we need to keep everyone in mind. I'm grateful to the chair and ranking member for working this in, and I know it will have a meaningful impact in my district and throughout our great country. With that, I urge my colleagues to support the amendment, and thank you for yielding.
You're in the, you're
Yes,
yielding? Okay.
I move to
Gentleman
strike
from
the
Maryland yielding to you?
Who's next?
The gentleman from Maryland yielding to you for time?
No.
Okay, it's his time, so I'm gonna go to the Republican side, then come back on the next. Perfect. Unless you're yielding, you're taking their time. You want your own time. Okay, perfect. So the chair, what purpose does the gentleman from Georgia seek recognition?
Move to strike the last word.
Gentleman from Georgia is recognized for 5 minutes.
Mr. Chairman, I'd like to speak in support of this package and the bipartisan bills that I'm leading which were included. I'm pleased to see that my Drug Price Transparency and Medicaid Act is included in this bill, which will bring transparency to the Medicaid program and address some of the most egregious practices of PBMs. This bill will protect patients, pharmacists, and taxpayers from the abusive practices of PBMs. For years, PBM practices in Medicaid managed care have obscured the true cost of prescription drugs, wasted hundreds of millions of taxpayers' dollars, and devastated community pharmacies by engaging in a practice known as spread pricing. In spread pricing, PBMs charge state Medicaid managed care programs more for prescription drugs than they reimburse pharmacies, allowing the PBMs to pocket the difference or the spread as excess profit. One managed care company has already paid out over $400 million to settle state investigations arising out of their spread pricing practices and has set aside more than $1 billion to resolve claims across the country. This legislation puts an end to the PBM games by prohibiting spread pricing, and as a result will save taxpayers more than $1 billion. $1 billion. So that states can further invest in the needs of their communities. This legislation also increases transparency by requiring pass-through pricing while utilizing and strengthening NADAC, which stands for the National Average Drug Acquisition Cost. NADAC is administered by CMS and is a public benchmark based on drug acquisition costs reported by retail pharmacies across the country and represents the most transparent and accurate market-based pricing available today. By utilizing and strengthening NADAC, states, taxpayers, and pharmacies will know the true cost of prescription drugs. On top of NADAC, this legislation brings transparency and fairness to community pharmacies by allowing them to be reimbursed at an appropriate rate for dispensing medications to Medicaid patients. As we all know, pharmacists are one of the most accessible healthcare professionals in America. 95% of all Americans live within 5 miles of a pharmacy. These are the people in our communities that care for our country's most vulnerable patients. Yet because of unfair and deceptive acts like spread pricing in Medicaid managed care system, 4% of independent pharmacies close every year. This bill finally puts a stop to that. The Drug Price Transparency in Medicaid Act ensures community pharmacies will be treated fairly and will not be driven out of business by large PBMs while they care for this nation's most vulnerable patients. I'm also pleased to support the Pharmacy Benefit Managers Accountability Act, which is also included in this bill. In Congress, we are focused on increasing the accessibility, affordability, and quality of health care. As we know, and we know that pharmacy benefit managers' anti-competitive tactics are driving up health care costs for Americans and harming patient care. That is why the PBM Accountability Act is an important first step towards bringing down prescription drug prices by addressing the root cause, the middlemen that prey on patients for profits. This legislation will increase reporting requirements of PBMs to shed a light on the opaque drug pricing system they use. This will empower patients and drive competition to ultimately make quality health care more affordable and accessible for patients and potentially save the federal government over $2 billion over the next 10 years. I applaud this committee. I applaud this committee for taking this critical first step and increasing transparency and accountability on these middlemen. I'd like to thank my colleagues on both sides of the aisle, for working with me on these important issues, and I would ask all of my colleagues on this committee to support this legislation. Mr. Chairman, as you know, this is an issue that I have worked on since day one that I got here. I'm very passionate about this and about drug pricing and about PBMs and the egregious practices. And I want to thank this committee. My colleague, Dr. Bouchon, earlier in this hearing told me, he said, we're making a dent finally, and we are making a dent. And it's this committee that's making that dent. And we're doing it in a bipartisan fashion. And I want to thank you for that, and I want to thank all the committee's members for that, and I yield back.
The gentleman yields back. The chair now recognizes Dr. Ruiz from California. What purpose does Dr. Ruiz seek recognition?
To move the strike, the last word.
The gentleman from California is recognized.
Like the chair and ranking member, I have been a longtime advocate for the Teaching Health Center Graduate Medical Education Program, and I've worked with both of them over the years to fund and expand the program. I'm sure that many of you, like me, have heard frustration over the lack of funding certainty with the program over the years. So I'm thrilled to see that it is being funded for 6 years under this measure. When a teaching health center program doesn't even know if their funding is going to continue, it makes it more difficult to recruit medical students. So I would like to thank the committee for addressing this issue in this reauthorization. I'm equally thrilled to see that funding will continue to increase significantly over time. so that we can continue to expand this successful program. Where a doctor is from and where they train are two major indicators of where they will practice. So training physicians in health centers that are located in and directly serve communities in need is critical in addressing the provider shortage, especially in underserved communities that is plaguing my district and the country. I would like to thank the chair of the overall committee and the ranking member of the overall committee for their work to provide robust and long-term funding for this critical program so that we can get more doctors in our communities with the greatest needs. I'm also pleased to see that the bill that I introduced with Congressman Cole, H.R. 2547, the Special Diabetes Program for Indians Reauthorization Act of 2023, is being included in this legislation. The resources provided by the Special Diabetes Program for Indians has a significant impact for tribes in my district and across the country. As a doctor, time and time again, I saw patients in the emergency department with preventable conditions related to their diabetes. And this problem continues to get worse, particularly in communities of color. In fact, American Indian and Alaska Native populations have the highest prevalence of diabetes in the United States. Reauthorizing this program is critical to reducing the incidence and mortality of diabetes, which is the 7th leading cause of death and the #1 cause of kidney failure, lower limb amputations, and adult blindness. So I urge my colleagues to support these critical programs, and I yield back.
Gentleman yields back. Mr. Joyce is recognized.
Mr. Chair, I move to strike the last word.
You're recognized.
Thank you, Mr. Chairman. I would like to add my support to the amendment in the nature of the substitute before us today to the Transparent Price Act, which would make crucial reforms to our healthcare system by increasing transparency and lowering costs for our patients. Specifically, I would like to highlight the bipartisan nature of H.R. 3237 included as part of this amendment and introduced by myself and Representative Sarbanes. H.R. 3237 will require hospitals to more clearly report to CMS on what services are occurring at each of their outpatient departments through a unique identification number at each facility. This legislation codifies recommendations from a 2016 HHS IG report that will ensure that our seniors are not paying higher copays inadvertently for care billed in an incorrect setting. While this legislation is a good first step, I do believe that there is more that can be done to ensure that seniors are not paying inappropriate out-of-pocket costs for the care that they receive across all settings. I look forward to having ongoing bipartisan conversations on this issue and moving more legislation in this area, while also looking to safeguard those hospitals that serve as critical points of care in our communities. This is why I also support H.R. 2665, the Supporting Safety Net Hospitals Act, also included in this package, which would avoid devastating DSH payment cuts to hospitals across the country, and especially in my district in Pennsylvania 13. I'm also pleased to see the inclusion of H.R. 2559, the Strengthening Community Care Act, which I introduced along with Chairwoman Stefanik, Representative Blunt Rochester, and Representative Fletcher earlier this year. I would like to thank all the co-leads on this piece of legislation, which would also extend the Community Health Center Fund for the next 2 years, while also providing crucial resource to support the work provided by these centers. This bill contains a critical increase in funding for the fund while ensuring that these dollars are fully offset. This critical piece of legislation would provide for community health centers across the country, including centers in my own district, like the Keystone Rural Health Center, Broad Top Area Medical Center, and the Hindman Area Health Center, which helps serve the needs of over 238,000 people in Pennsylvania 13. This AINS also contains increased resources for the National Health Service Corps, which provides scholarship and loan repayment to more than 20,000 healthcare providers practicing in underserved areas. The NHSC is a key part of the long-term solution to workforce shortages in underserved areas. According to data from HRSA, 86% of NHSC clinicians continue working in a health professional shortage area after completing their service obligations. Mr. Chairman, I would like to ask unanimous consent to enter into the record two letters of support for this legislation, one from the National Association of Community Health Centers and one from the Pennsylvania Association of Community Health Centers.
Without objection.
Thank you, Mr. Chairman. I urge all of my colleagues to participate in adoption of the AINs and yield the balance of my time.
Gentleman yields back. Does anyone seek recognition on the Ains? For what purpose does the gentlelady seek recognition?
I move to strike the last word.
Gentlelady is recognized for 5 minutes.
Mr. Chairman, I'm proud that two of my bills to increase transparency and lower patient costs are included in today's markup. Last year, 40% of Americans put off needed medical care because of the cost. We know people are choosing not to fill their medications or rationing their supply because the cost of prescription drugs is burdening families. In the United States of America, that's unacceptable, and it's time for us to change the system. We can start by looking at the steps between when a drug is made and when it gets into the patient's hands. My bipartisan bill, the PBM Accountability Act, will increase transparency requirements for pharmacy benefit managers who play an important behind-the-scenes role in setting the price of prescription drugs. The PBM Accountability Act will help shed light on how decisions on pricing are made by requiring that PBMs file regular reports about how some drugs are covered, valued, and categorized. Increasing transparency around PBMs will help improve the prescription drug pricing system, ensuring that patients are able to access and afford the drugs that they need. I thank my colleague, Chairman Guthrie, Ranking Member Eshoo, and Representative Buddy Carter for their partnership on this issue. This is bipartisan, common-sense policy to eliminate unnecessary hurdles in accessing lower-cost drugs. Another barrier that patients face when they're prescribed medication is the high price of brand-name drugs and lack of availability of lower-cost generic options. I've been working closely with both generic drug manufacturers and the FDA to identify ways to bring generic drugs to market faster. I'm glad that a version of my bill is included in today's markup, the Increasing Transparency in Generic Drug Applications Act. This policy promotes lower-cost generic options for patients by ending the guessing game that manufacturers play when submitting an application to the FDA. The Increasing Transparency in Generic Drug Applications Act requires FDA to inform manufacturers about the differences that their product has from the brand name or reference product. These differences can prevent the application from moving forward, delay the generic drug from coming to market, and unnecessarily increase costs for consumers and for the federal government. To improve this process, we've allowed the FDA to share more details with manufacturers about the differences between their proposed generic and the name brand. This will remove a needless hurdle that manufacturers have to face to bring their product to patients. While I'm pleased to see this general policy is considered today, what's in front of the committee is not the most effective path forward. We need to be able to give manufacturers specific details about how to change their application instead of just telling them, quote, more or less. The Senate Health Committee passed a policy that would empower FDA with these specific details by a bipartisan vote 19-2. We need to allow the FDA to use all the tools at their disposal to advance prescription drug innovations. Therefore, I urge this committee to consider changes to the bill to make it effective as possible. I thank you again to my colleagues in the committee for supporting these important policies, and I look forward to working with you to increase transparency and lower healthcare costs for people across the country, and I yield back.
Gentlelady yields back. Does anyone else seek recognition on the Ains? For what purpose does the gentlelady seek recognition?
I move to strike the last word, Mr. Chairman.
Gentlelady is recognized for 5 minutes to strike the last word.
Thank you. You know, I'm pleased that the amendment in the nature of a substitute for the Transparent Price Act contains a number of bipartisan bill reform ideas to improve transparency and competition in health care and deliver lower costs to patients. These reforms are long overdue, and having served as a community pharmacist for over 30 years, one of the top priorities that I have is to ensure affordable and high-quality health care for people all across the country. We all hear about how our constituents are struggling to keep pace with spiraling health care costs, and they end up owing significant medical debt, and they're urgently pleading that we work to provide meaningful solutions. On top of high costs, patients are also navigating a confusing landscape where they can't realistically plan for how much life-saving treatment's going to cost or if they can even afford it. And I'm grateful that the committee's worked with me and my colleagues, Rep. Schreier and Bilirakis and Schakowsky, to include in this legislation our bipartisan bill, the Promoting Transparency and Healthy Competition in Medicare Act. Patients do have legitimate questions about what to think when their insurance company owns the doctor they see, the pharmacist they get their medicine from, and the PBM that decides how much they pay for the medicine. In order to address these questions and ensure Medicare is delivering quality care and a fair deal to patients, we have to have transparency from healthcare entities that have consolidated so many aspects of healthcare delivery under their umbrellas. This legislation also contains important pharmacy benefit manager transparency and accountability reforms. I fully support the bills offered by Reps. Custer and Carter that will require PBMs to provide annual reporting to plan sponsors of certain important data that would put sponsors in a better position to negotiate with the PBMs. It's expected that this information can be used to lower PBM contract costs, so today is all about healthcare transparency, which is what the American public has asked us to do. And with that, Mr. Chairman, I yield back.
Would the gentlelady yield the remainder of her time?
Yes.
Thank you very much. I moved to strike the last word as well. I'd like to speak very strongly in favor of this important package, which will inject much-needed transparency into virtually every sector of the healthcare system. The American healthcare system is at a point where incentives have become so perverse and the market so distorted that consumers are totally in the dark about how much they're going to pay for care. Today, a complicated web of markups, rebates, fees, and ever-changing business models designed, in fact, intended to shroud prices in complexity, keeps patients in the dark about the true cost of medicine and treatment. A functioning market requires informed and empowered consumers. And I would like to thank my colleague, Congresswoman Custer, for working with me and my staff on a policy included in this package, which will expedite the entry of lower-cost generic medicines to market. I think we can all agree that generic manufacturers should not have to play a complicated guessing game with the FDA to bring safe, effective, affordable drugs to market. Our policy ensures that generic applicants get precise feedback on their applications, and it unsticks a burdensome regulatory process. Further, with CBO predicting this policy to save $600 million over the next 10 years, this committee is able to invest those savings into important programs such as community health centers, National Health Service Corps, and graduate medical programs. I appreciate the negotiations that got us to this place, and I appreciate the work on this policy. With that, I yield back.
I yield back.
Gentlelady yields back. Does anyone seek recognition on the Ains?
Over here.
For what? Ms. Blunt Rochester is recognized for 5 minutes.
Thank you, Mr. Chairman.
Strike the last word.
I move to strike the last word, and it's been struck and stricken. Thank you, Mr. Chairman. I want to, first of all, say how very proud I am of the bipartisan work that has gone into this package, especially the reauthorization of several important public health programs. I'm particularly pleased at the progress we've made on the reauthorization of the Community Health Center Fund and the National Health Service Corps. That is based on the work I did with my colleagues, Representatives Joyce, Fletcher, and Stefanik. The Ains we are considering today would extend the Community Health Center Fund and the National Health Service Corps for 2 years and includes an increase providing near-term stability and predictability to health centers nationwide. This program is critical because health centers typically treat a sicker, poorer, and more diverse population than most other health care providers, serving 1 in 5 rural residents, 1 in 3 living in poverty, and over 400,000 veterans. And of the 30 million patients served by health centers, almost a third are children, and 11% are older than 65. A strong health center network is integral to promoting health equity and increasing access to primary and preventative care to people at every stage of life. And I would venture to guess that every member of this committee has constituents who have benefited from health center services. I hope that this reauthorization will be the beginning and not the end of the discussion. And I want to acknowledge the work that I've done with my colleagues, Representatives Barragan and Custer. Together, we put forth a policy to provide smart and targeted investments to help health centers deepen their services and address the most urgent issues facing Americans today, like the opioid crisis. Health centers have enormous potential to play in a leading role in reducing overdose deaths and improving the mental health of Americans. In 2021, 1 in 5 Americans had a mental health condition, and over 100,000 Americans died from drug overdoses. Behavioral health conditions are most prevalent among Medicaid enrollees, which is also the largest population served by health centers. And although most health centers provide mental health and substance use disorder care, they are currently not required to do so. Health centers saw an increase of 138,000 patients for behavioral health visits between 2020 and 2021. But despite their efforts, health centers are only meeting 27% of the demand for mental health services, 27%, and 6% for the demand of substance use disorder services among their patients due to resource constraints. Therefore, millions of healthcare center patients still lack access to those critical services, including mental health and addiction treatment. I encourage members to take a look at our bill, H.R. 3080, and the President's proposal, because I think it lays out a clear and compelling justification for why health centers should be given more resources. I look forward to continuing the conversation, and I urge my colleagues to support this aims. Thank you, and I yield back, Mr. Chairman.
Gentlelady yields back. Does anyone seek recognition on the Ains? For what purpose does the gentlelady seek recognition?
I move to strike the last word on the amendment nature of a substitute to H.R. 3281.
Gentlelady is recognized for 5 minutes to strike the last word.
Thank you, Mr. Chair. I speak in support of all of the bills that are within this Ains. Specifically, as a state senator, I had passed a transparency bill on pharmacy benefit managers, and I think this is an important step forward into helping patients and consumers to control prescription drug prices. I also appreciate that my bill, H.R. 3248, the Diagnostic Lab Testing Transparency Act, is included in this important amendment. This bipartisan bill, which I'm proud to be leading with Congresswoman DeGette, ensures that patients can meaningfully shop for lab tests by extending modest price transparency requirements to labs. Specifically, our bill requires diagnostic laboratories to disclose 3 data points for clinical diagnostic laboratory tests included on the list of shoppable services specified by the Centers for Medicare and Medicaid Services: the discounted cash price, the de-identified minimum rate, and the de-identified maximum rate. With transparency for insurers, also, this will help to lower costs for patients. These requirements, coupled with better implementation of the advanced explanation of benefits provisions from the No Surprises Act, will allow patients to meaningfully shop amongst their local labs for the same tests they can currently shop for at their local hospital. Increasing price transparency empowers patients by ensuring they have access to accurate pricing information for diagnostic lab testing services. Price transparency increases competition, which leads to lower prices. This not only saves Americans money, but also reduces overall cost of the healthcare system. I urge my colleagues to support the ANS, and thank you, Mr. Chairman. I yield back.
Gentlelady yields back. Does anyone else seek recognition to speak on the Ains? For what purposes does the gentlelady seek recognition?
Mr. Chairman, I move to strike the last word.
Dr. Schreier is recognized for 5 minutes to strike the last word.
Thank you for bringing up this package, and I'm so pleased to see so many bipartisan priorities in transparency and the healthcare workforce. I'd like to call attention to a few issues. One, I'm happy to see the reauthorization of the special diabetes program, especially as somebody with type 1 diabetes. It includes vital programs to ensure progress on predicting, delaying, treating, possibly even curing type 1 diabetes. And one example is the never-ending quest for an artificial pancreas. These programs are also really crucial in helping patients manage diabetes and its complications. I was also thrilled to see a 6-year reauthorization of the Teaching Health Center graduate medical education. Medical residents, especially those training in clinics in rural or underserved areas, have expressed to me a great deal of anxiety that the funding for their program might dry up before they finish their training. This will bring those residents peace of mind, and it'll make it more likely that medical students will choose some of these smaller programs that are really critical for ensuring access to healthcare in rural and underserved areas. I'm really glad we're moving forward with this package of bills that'll bolster our healthcare workforce and bring transparency. I'm especially grateful that H.R. 3282, the Promoting Transparency and Healthy Competition in Medicare Act, introduced by me and Dr. Harshberger, is included in this markup. This bill looks at companies that own multiple lines of the healthcare business. For example, companies that own the insurance plans and the pharmacy benefit managers, and maybe even the pharmacy and the physician group as well. And it just gives us a little sight into parts of the healthcare system where there is not transparency and there's a lot of confusion. There's concerns, valid concerns, that consolidation in this industry might disincentivize competition. It could lead to higher prices for our patients or less access to important medications. I hear from my constituents every day about the rising cost of healthcare. I hear confusion about which plans offer which medications and who can get which medications. I've had people call our office concerned and confused as to why their insulin is not covered by their Medicare Advantage plan. So looking at how companies that own both the insurance plan and the PBM interact with healthcare providers that they share common ownership with, like physician groups, pharmacy benefit managers, and pharmacies, compared to those that do not, will allow us to see either incentives or disincentives that cause the cost of care to go up or down, and to see whether these really benefit patients or not, and that's really at the heart of the matter. A lot of this information is already out there, but not in a streamlined place where we can all access it. And I am hoping that this will help us ensure delivery of high-quality, affordable care and medications to our constituents. I encourage my colleagues to vote yes on this AINS, and I yield back.
Generally yields back. Is there anyone else seeking recognition on the AINS? If not, are there any bipartisan amendments to the AINS?
Well, not by.
Are there any?
I have an amendment.
Is that what I was supposed to say? Yep. Ms. Trahan, recognized for 5 minutes.
Thank you, Mr. Chairman. I have an amendment at the desk. It's labeled AMD 01.
Clerk will report the amendment.
Oh, sorry. Yes. Are there any bipartisan? Can I keep going?
Okay. The clerk will report the amendment.
Amendment to the amendment in the nature of a substitute to H.R. 3281, offered by Mr. Hand. Page 90, lines 12 through 24, strike.
Without objection, the reading of the amendment is dispensed with, and the gentlelady is recognized for 5 minutes in support of the amendment.
Thank you. This amendment is simple. It would strike from the underlying AINS provision a provision that would require the annual appropriations rider, referred to as the Hyde Amendment, to also apply to the reauthorization of community health centers and teaching health centers program, as well as the National Health Service Corps. For too long, the Hyde Amendment has banned federal funding for abortion and has pushed abortion care out of reach, resulting in the denial of needed health care for too many. We know that federal funding bans on abortion care are detrimental to millions, and the harm is not felt equally. These restrictions are discriminatory and disproportionately impact those working to make ends meet, young people, women of color, and those in the LGBTQ community. When women are denied coverage for abortion, it can threaten their economic security, push their families into poverty, and exacerbate already existing health inequities. In the wake of the Supreme Court's devastating decision in Dobbs versus Jackson Women's Health Organization, which has resulted in the denial of abortion care or severe restrictions on care in dozens of states, provisions like the one included in the AINS only places abortion care even further out of reach and denies people the freedom to make their own decisions about their bodies, about their own lives, their families, and their futures. We should be working to ensure all women have access to comprehensive reproductive health care, not erecting more barriers that block access and deny care. That is why I oppose the underlying provision in the AINS and urge my colleagues to support my amendment. I yield back.
Generally yields back. Is there any discussion on the amendment?
Mr. Chairman.
The chair of the full committee, Ms. Rodgers, is recognized for 5 minutes.
Thank you, Mr. Chairman. I'd like to strike the last word, speak in opposition of the amendment.
Gentlelady is recognized.
Abortion is the most divisive issue in America today. It pierces every heart. The question before this committee, as many times before, is whether taxpayer money should be used to fund abortions. We know that the vast majority of Americans believe taxpayer dollars should not be used to fund abortions or subsidize insurance plans that cover abortions. The Hyde Amendment has been the law of the land for decades, with support from both Republicans and Democrats. Specifically, for community health centers, teaching health centers, and the National Health Service Corps, Hyde has always been applied to mandatory funding. The last 3 times we have provided mandatory funding, Congress has applied Hyde protections in a bipartisan way. However, the Democrats on our committee are now proposing to eliminate Hyde for these programs. It's just the latest example of an extreme abortion agenda. And I want to be clear about abandoning Hyde is not the will of the American people. Until recently, abandoning Hyde protections wasn't the position of President Biden, someone who once adamantly defended the Hyde Amendment. I also want to make clear that I'm not talking about people's opinions regarding the legality of abortion or access to abortion services. The issue before us today in this amendment is whether it is right to federally subsidize abortions. I would submit this is not the will of the people. They do not want to be forced to fund something with taxpayer dollars that is against their conscience. I yield back.
Generally yields back. Is there further discussion on the amendment? For what purposes generally seek recognition?
Mr. Chairman, I move to strike the last word.
Generally is recognized for 5 minutes.
Thank you, Mr. Chairman. I speak in support of this amendment that would strike from the underlying AINS a provision applying the Hyde Amendment to the reauthorization of community health centers, teaching health center programs, and National Health Service Corps. Every person should be able to make decisions about abortion with dignity and respect and without lawmakers interfering, and a majority of Americans agree. It is unconscionable to force someone to carry a pregnancy against their will, and yet that's what the Hyde Amendment does, and similar abortion coverage bans. Since the Supreme Court's decision in the Dobbs v. Jackson Women's Health Organization case closed to 20 states have moved to ban or restrict abortions. Against this backdrop, the Hyde Amendment provisions in this AINS further pushes access to abortion out of reach where abortion is now outlawed and makes it worse for people even in states where it remains legal. Simply put, abortion funding bans like the Hyde Amendment are discriminatory, are not felt equally among people, and negatively impact the physical, mental, and emotional health of people across this country. I urge my colleagues to vote yes on this amendment. Thank you, and I yield back.
Generally yields back. Is there further discussion on the amendment? If there's no further discussion, oh, okay. Gentlelady seek recognition.
Thank you, Mr. Chairman. I move to strike the last word.
Gentlelady is recognized for 5 minutes.
I would like to support support this amendment. I want to just make clear that depending on the phrasing that you use, if you say taxpayer dollars for abortion, many people bristle at that. When you explain that this is an attack on poor women, that it means that women on Medicaid cannot have the same access to services as other women, women with private insurance, that opinion quickly changes because everyone should have access to the health care that they deserve. I yield back.
Generally yields back. Is there further discussion on the amendment? Seeing none, the vote occurs on the amendment, and a roll call vote is requested, and so the clerk will call the roll.
Chair Guthrie. Chair Guthrie votes no. Mr. Burgess. Mr. Latta. Mr. Latta votes no. Mr. Griffith. Mr. Griffith votes no. Mr. Bilirakis. Mr. Bilirakis votes no. Mr. Johnson. Mr. Johnson votes no. Mr. Bouchon.
No.
Mr. Bouchon votes no. Mr. Hudson. Mr. Carter. Mr. Carter votes no. Mr. Dunn. Mr. Dunn votes no. Mr. Pence. Mr. Pence votes no. Mr. Crenshaw. Mr. Joyce. Mr. Joyce votes no. Ms. Harshbarger. Ms. Harshbarger votes no. Ms. Miller-Meeks. Ms. Miller-Meeks votes no. Mr. Obernolte. Mr. Obernolte votes no. Chair Rodgers. Chair Rodgers votes no. Ms. Eshoo. Can the gentlelady repeat her vote? Ms. Eshoo votes aye. Mr. Sarbanes. Mr. Sarbanes votes aye. Mr. Cardenas. Mr. Cardenas votes aye. Mr. Ruiz. Ms. Dingle. Ms. Dingle votes aye. Ms. Custer. Ms. Custer votes aye. Ms. Kelly.
Aye.
Ms. Kelly votes aye. Ms. Badagan. Ms. Blunt-Rochester. Ms. Blunt-Rochester votes aye. Ms. Craig. Ms. Craig votes aye. Ms. Schreier. Ms. Schreier votes aye. Mr. Hand. Mr. Hand votes aye. Mr. Pallone. Mr. Pallone votes aye.
Does anyone else seek recognition to vote?
How did Reese vote?
Mr. Ruiz is not recorded.
Aye.
Mr. Ruiz votes aye.
Mr. Burgess, how's Mr. Burgess recorded?
Mr. Burgess is not recorded. Mr. Burgess votes no.
How's Mr. Crenshaw reported?
Mr. Crenshaw is not recorded. Mr. Crenshaw votes no.
How's Mr. Hudson recorded?
Mr. Hudson is not recorded. Mr. Hudson votes no.
How's Ms. Barragan recorded?
Ms. Badagan? Ms. Badagan is not recorded. Ms. Badagan votes aye.
Seeing no one else, the clerk will report the result.
Chair, on that vote, we have 13 ayes and 17 nays.
The nays have it. The amendment is not agreed to. Are there any further amendments? The chairwoman of the full committee, Ms. Rodgers, is recognized to offer an amendment.
Thank you. Mr. Chairman, I have an amendment at the desk, Amendment 02.
Amendment to the amendment in the nature of a substitute to H.R. 3281, offered by Ms. Rodgers. Add at the end of Title III the following new section.
Objection, the reading of the amendment is dispensed with. The gentlelady is recognized for 5 minutes in support of her amendment.
Thank you, Mr. Chairman. At previous hearings, we've heard numerous stories and data points that all said the same thing. Medicare and patients are paying more for certain services in hospital outpatient department than they pay at the doctor's office. We heard from cancer patients who are fed up with seeing the cost of their chemo increase when a hospital purchases their infusion center. We heard about a senior citizen whose cost for an annual shot went from $30 to $1,400 just because her outpatient clinic reclassified itself as an entity of the local hospital. And we've heard strong support for ending this payment disparity from experts and advocacy groups across the ideological spectrum, from the Progressive Policy Institute to Americans for Tax Reform. This amendment follows the nonpartisan Medicare Payment Advisory Commission's proposal to ensure that Medicare and seniors pay the same amount for certain services, regardless of where they are performed. First and foremost, this proposal would directly save patients billions of dollars in healthcare costs. It would strengthen the healthcare system more broadly by ending one of the major driving forces of healthcare provider consolidation, which has resulted in less competition and access to quality healthcare options around the country. It is not a secret that hospitals have concerns with these proposals. As I said in our last hearing on the topic, hospitals are integral. They're integral parts of our communities, and we recognize the effects of high labor costs, inflation, and ever-increasing government regulation. We know that hospitals and the services that they provide often lose money. We rely on emergency departments that are open 24 hours a day, 7 days a week, for example. But I reject the premise that the only way to make hospital financials work is to cross-subsidize lost leaders by making patients and Medicare overpay on certain services, especially when we know that these policies come with unintended consequences of consolidation and less competition. Figuring out how to more directly and accountably subsidize hospital services without unintended consequences is difficult, and we have more work to do on these proposals to ensure access to care is preserved. So I will withdraw this amendment, but I remain committed to advancing these policies on behalf of patients, and I implore the hospital community to work with us on broader reimbursement changes that preserve access to care while making these key changes to help patients and strengthen the healthcare system. Lowering healthcare costs is a top priority of mine, and I'm committed to additional work on these policies with the Ranking Member Pallone and members of this committee to follow up on these important steps we're taking today. Mr. Chairman, I yield back.
The gentlelady yields back. The amendment is, the gentleman from New Jersey is recognized for 5 minutes to speak on the amendment.
Thank you, Mr. Chairman. I want to thank Chair Rodgers for her comments, and if I could just develop a little on my opinion. As I mentioned in my opening statement, I am concerned that Medicare currently pays substantially more, sometimes more than 2 or 3 times, for low-complexity services delivered in hospital outpatient departments compared to a physician's office. This difference in payment for the same service provided at different sites of care increases the cost to the Medicare program and, more importantly, increases the out-of-pocket costs of beneficiaries. I believe that drug administration is a clear-cut example of a low-complexity service that can be performed safely in a physician's office. So I want to thank the chair for the bipartisan work on this policy and the important investments that we can make in the DISH program with the associated savings from this policy. And I welcome continued discussions on policies that can lower costs for consumers and reinvest in our healthcare system. But of course, we have to closely examine any additional site-neutral policies to ensure that they do not jeopardize patients' access to care. And I look forward to working with you, Chair Rodgers, in a bipartisan manner as we consider any of the policies moving forward. And thank you again. Thank you, Mr. Chairman.
Thank you. The ranking member yields back. With seeing no further discussion, the amendment's withdrawn. Is there anyone seeking purpose recognition for an amendment? The gentlelady from Michigan, for what purpose do you seek recognition?
Mr. Chairman, I have an amendment at the desk.
The clerk will report the amendment.
Amendment to the amendment in the nature of a substitute to H.R. 3281, offered by Mr.
Without objection, the amendment, the reading of the amendment is dispensed with, and the gentlelady from Michigan is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. This amendment increases funding levels for the community health centers and the National Health Service Corps and brings them into parity with the President's fiscal year 2024 budget request. Let me begin with community health centers. Community health centers are absolutely essential. They play a vital role in the U.S. healthcare system and are a major contributor to keeping Americans healthy. Currently, over 30 million Americans depend on CHCs for access to crucial primary care, especially patients in rural, underserved, and our most vulnerable communities. It's the only place that they can go. I know we all care deeply about CHCs, and I'm very appreciative of the modest funding increase that is included as part of the AIMS. And I cannot tell you how grateful I am to Representatives Stefanik, Joyce, Blunt Rochester, and Fletcher for their leadership and longstanding support for CHCs. I get it. We're in a tough fiscal environment. But if the pandemic has taught us anything, it's about the importance of investing in healthcare now to improve outcomes later. Community health centers have needs beyond the funding levels appropriated in this AIMS, and I firmly believe we should be doing even more to help CHCs keep pace with inflation, expand the scope of their important work, and ensure they have a presence in every underserved community. But to achieve this, we must also have a robust primary care workforce that is able to meet patients' evolving needs. Growth in the number of health centers has led to a significant increase in the number of patients who receive care at CHCs, and this growth has necessitated a stronger primary care workforce. In fact, we continue to hear from the CHCs about the need for more health providers to address the steady increase of patients coming through their doors. And that's why programs like the National Health Service Corps are integral. Since 1972, it's been an invaluable tool in strengthening and growing the primary care workforce. And in the wake of the COVID-19 pandemic, the worsening workforce crisis, the National Health Service Corps is more important than ever. I'm offering this amendment to reaffirm my commitment to supporting community health centers and the workforce that serves them, but I am prepared to withdraw it. It is my hope we remain mindful of the invaluable critical role community health centers play and keep this perspective in mind as this legislation advances to the full committee. Thank you, Mr. Chairman, and I yield back.
Thank you. The gentlelady yields back. Anyone discussing Mr. Cardenas from California? Yes. Mr. Cardenas, California, what's in on our side? No one seek recognition. Mr. Cardenas from California, recognized for 5 minutes.
Thank you so much, Mr. Chairman. I move to strike the last word. I want to thank my colleagues who have worked tirelessly to fund community health center legislation. This includes Representative Joyce, Representative Blunt Rochester, Representative Stefanik, and Representative Fletcher, who are leading the fight to strengthen Community Care Act. I also want to thank committee leadership who have negotiated increased funding in this proposal. Getting bipartisan agreement on funding for community health centers is critical to ensuring quality care will be provided to our most vulnerable populations. However, I also want to take this opportunity to highlight why I think the funding levels spelled out in the President's budget would help enhance the scope, reach, and scale of care that health centers can provide. I've seen firsthand in my own life the value of these facilities. For much of my youth, community health centers were the one place that myself and my 10 brothers and sisters and my mother and father could get medical attention instead of having to go to the emergency room. That was a long time ago, but today, it's still a reality for too many families. Without community health centers, 15 million more patients would be at risk of going without steady sources of primary care. And this access to community health centers is not just good for patients, it's good for our wallets and good for our country. Research indicates that for every dollar invested in primary care, $13 is saved in costs on the back end. In other words, access to primary health care and preventative services is essential to improving health outcomes and reducing the financial burden for patients. It is also clear that as a country, we are struggling with a mental health and addiction crisis. For example, in 2021, 55% of health centers provided substance use disorder services to hundreds of thousands of patients across the country. We all know how critical this crisis is. Community health centers are a key piece of our healthcare ecosystem, and without their promise of quality care, we will only see sicker patients and much, much higher costs. At the levels indicated in the President's budget, we can diversify the types of services provided, expand the reach of these services, and ensure critical care is delivered no matter a patient's ability to pay. I believe this is an important amendment that will provide critical increase for communities in need. And I'm grateful to my colleague, Ms. Dingle, for bringing this up for discussion. And with that, I yield back.
Thank you. The gentleman yields back. Anyone seeking discussion on? The gentlelady from California is recognized for 5 minutes.
Thank you, Mr. Chairman. I move to strike the last word. First of all, I'm happy that we're here talking about increases to community health centers and to consider policies to help to lower cost for patients and respond to the fiscal challenges that FQHCs are facing. I myself also am a product of the use of community health centers as a child would go to, and that's where we got our source of care. And today, it seems like there's even a greater need for community health centers and FQHCs, and so I'm glad to see this Dingle amendment would increase funding levels for federally qualified health centers consistent with President Biden's FY24 budget proposals. We're also seeing that right now with Medicaid unwinding, there could be millions of people, up to 24 million people, could lose their Medicaid coverage. So it's a time where we need to continue to invest in healthcare and invest in access to healthcare. That includes FQHCs and community health centers. But I think it's critically important that we not only increase, but we increase at a higher level. That's why I'm proud to co-introduce with my colleague Lisa Blunt-Rochester and Ms. Custer the Health Center Service Expansion and Provider Shortage Reduction Act. And really feel like this is something we need to look at and discuss and talk about and pass. It would invest $700 million annually into our FQHCS so they are equipped with the tools and the funding needed to meet patients' increased mental and behavioral health need. It would also provide an additional $250 million investment to support increased hours of operation and provide $150 million in new access point funding targeted to the areas of highest need. I look forward to working with anybody and everybody who is willing to support this investment. We talk a lot about the need of more access to mental health, but we need to invest those dollars to make that possible. And so with that, I just wanted to express my support for the amendment and for this other bill that would further increase funding. Thank you, and with that, I yield back.
Thank you. The gentlelady yields back. Anyone seeking recognition? What purpose does the gentlelady from Delaware seek recognition?
I move to strike the last word.
Gentlelady is recognized for 5 minutes.
Thank you, Mr. Chairman. I speak in support of this amendment to extend the Community Health Center Program and National Health Service Corps at the level of the President's budget request. Health centers are the model healthcare safety net because they care for the underserved while being good stewards of federal dollars. For every dollar invested in health centers, Medicare and Medicaid save approximately $5. In 1 year, that translates to about $25 billion in savings. I can't think of many other cases where the return on investment is so substantial. The President's proposal that would be supported by the funding levels in this amendment would expand the depth of services of health centers and allow them to serve millions of more people. And it would also help underserved communities recruit and retain healthcare staff, which is critical in the midst of a workforce shortage that we are facing today. Specifically, this amendment would help, and I'm going to reiterate. Number one, assist all health centers in providing mental health and substance use disorder services under Section 330 of the Public Health Service Act and provide $700 million annually to implement this new requirement. Number two, support increased hours of operation, including extended or weekend hours through an annual $250 million investment. This would increase access for those unable to take off during work or who work non-traditional hours or who live in rural or remote areas. Number three, provide $150 million in a new access point funding opportunity targeted to areas of highest need. The last time HRSA awarded funding for new access points, HRSA was only able to fund 75 out of the 550 applications. Number four, provide additional funding to enable the NHS to support its current field strength by recruiting primary care, behavioral health, and dental health care providers to areas of greatest need. Through these investments, health centers would be able to deliver quality, cost-effective care to over 3 million more patients and support thousands of new healthcare loan repayment and scholarship awards. I ask unanimous consent to enter into the record a letter signed by 140 organizations from 27 states and the District of Columbia supporting this effort. Thank you, and I yield back.
Gentlelady yields back. Any other discussion on the amendment? The gentlelady from Michigan has withdrawn her amendment, so the amendment is withdrawn. Are there any other amendments to the bill? Mr. Carter from Georgia?
Yes, Mr. Chairman, I seek recognition to offer an amendment.
Gentleman's recognized. What amendment? What?
Amendment is CART Georgia 040.
Clerk report.
Amendment to the amendment in the nature of a substitute to H.R. 3281, offered by Mr. Carter of Georgia.
Without objection, the reading of the amendment is dispensed with, and the gentleman from Georgia is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Chairman. Mr. Chairman, I'd like to offer this bipartisan amendment that I'm leading with Representatives Berrigan, Miller Meeks, and DeGette. This bipartisan amendment, the Help Copays Act, is a must-pass policy. As a pharmacist for over 4 decades, I have seen firsthand the role pharmacy benefit managers play in driving up costs for medications and delaying necessary treatments for patients. I was the one who was on the other side of the counter who had to tell the patient how much their insulin cost. I was the one who watched the senior citizens trying to decide whether they were going to buy their insulin or buy groceries. I was the one who watched a mother cry because she couldn't afford the medication for her child. I was the one who watched all that happen. And I knew behind the curtain that the pharmacy benefit managers are the root cause of high prescription drug costs and inaccessible health care. Fortunately, we are here today to make real changes for patients. We have an opportunity here to stand up to the PBMs and finally bring relief to patients. As we all know, PBMs have vertically integrated with the entire healthcare system. Just 3 PBMs, Caremark, Express Scripts, and OptumRx, control 80% of the market. Where is Teddy Roosevelt when you need him? These major PBMs are also now vertically integrated and own the insurance company and their own pharmacies and even providers in some cases. PBMs have stated that their role is to control costs and lower premiums. However, when's the last time your premium went down? This vertical integration has allowed them to continue to drive up patient costs and increase their own profits. One way they do this is through the use of copay accumulator schemes that health plans and PBMs use to pocket a patient's copay assistance by excluding the cost-sharing assistance from counting toward a patient's deductible or out-of-pocket minimum. Only health plans and PBMs could take a program designed to reduce patients' out-of-pocket prescription drug costs and turn it into a money-making machine. After the copay assistance card runs out, patients can be hit with surprise 4-figure refill bills until the deductible or the max is met. My bill, the Help Copays Act, would bring much-needed relief to vulnerable and chronically ill patients by ensuring that all payments, whether they come directly out of a patient's pocket or with the help of copay assistance, count toward their out-of-pocket cost. Especially now, with inflation near 40-year highs, Congress must use all tools at its disposal to help vulnerable patients stretch the value of their dollar. Now, let me be clear. Opponents to this legislation are choosing to prioritize insurer and PBM profits over savings for patients. Accumulators are profit-making programs for insurers. They have no benefit for patients, but they have significant financial benefits for insurers and PBMs. The Help Copays Act would immediately reduce costs for patients at the pharmacy counter. We should act to end this practice. That is why the Help Copays Act is critical to make sure patients get the drugs that they need. I applaud the work being done today on PBM transparency, but we must continue to do more.
I understand that the Help Copays Act is not on the agenda today, but I would like to work with the committee to ensure that it is ready for consideration at a future markup. I'm willing to work to make changes. I'm willing to compromise. I'm willing to make sure that we do the very best that we can on this. I'm willing to make those changes, and I implore the chair to work with us to find a mutually agreeable path forward. But we must retain the savings for patients and end these programs. 11 members of this committee are on this legislation, including 9 of my colleagues across the room from me. Let's put patients ahead of profits. Thank you, Mr. Chairman. And if no other members wish to speak on the amendment, I will withdraw my amendment and yield back. If there's someone who wants to speak, I'll be glad to hear from them.
The gentleman yields back his time, and the chair recognizes the gentlelady from California. What purpose does the gentlelady from California seek recognition?
I move to strike the last word.
Gentlelady's recognized.
Thank you, Mr. Chairman. Thank you to my colleague, Representative Carter, Diana DeGette, Miller Meeks, for working to co-lead this Help Copays Act, and I support this amendment. Now, the Help Copays Act was first introduced by our colleague, the late and great Representative Don McMorris. This was his flagship health care bill. And he introduced this in the year 2017. I am proud to continue his work, and that we are continuing his work to protect patients against the high cost of prescription drugs. He was a gentle giant, a compassionate champion for patients, an understanding dad, and I had the pleasure of serving with him as the co-president of the 115th class. Everyone loved Don and respected him, and I hope that both the chair and the ranking member will work with us to find agreement to advance this bill in honor of Don's memory, in the honor of the work that he's done. Because as was mentioned, the high cost of prescription drugs is hurting patients, it's hurting our constituents, and disproportionately impacts Latinos, with 1 in 3 Latinos being unable to fill their prescriptions because of costs. Many families depend on copay assistance programs to offset high drug prices that treat chronic conditions like arthritis, and cystic fibrosis, and multiple sclerosis. However, insurers and PBMs use copay accumulator programs to increase their profits at the expense of patients. And it's time that we say no more, and that we stand on the side of patients, and again, honor the memory of the late Donald McMorris, our colleague. And with that, I yield back.
Would the gentlewoman yield?
I will yield.
Thank you. I want to add my voice to what has been said about what is at hand right now and before it's withdrawn. We are marking up a lot of bills today. A great deal of work has gone into them. Every member on both sides of the aisle has a legitimate pride in that. I think one of the high water marks of this Congress out of the Energy and Commerce Committee is to address the abuses of PBMs. I can hear my father's voice. Honey, it's a racket. This is hurting people across the country. There isn't any merit to this. No matter which way you look at this, as if it were a rubric cube, each element of that cube is not any value added. So it's up to us. It really is up to us. And whatever needs to be worked out without gutting the legislation. Work out does not mean dilute it, so it doesn't mean anything. We need to get this done. We need to get this done. And the testimonies of whose original legislation, Congressman McMorris, and his wish on his deathbed, and all the good people that are working on this, we owe it to the people of this country, every single one of us, all of our constituents. We have to address this in the system. And when we do, it'll really be an hallelujah day. So I'm with you all on it. Let's get this thing done. Yield back.
Thank you. Gentleladies from California yield back. And any further discussion on the amendment? Seeing no further discussion on the amendment, the gentleman has withdrawn the amendment. Are there any other amendments to the amendment, nature of a substitute? Any other amendments? Gentlelady from Delaware, what purpose do you seek recognition?
I move to strike the last word, Mr. Chairman.
To offer amendment.
Thank you, Mr. Chairman. I am offering this amendment, which is intended to, I intend to withdraw, that would establish a national nursing workforce.
I'll have the clerk report. Would the clerk report the amendment?
Amendment to the amendment in the nature of a substitute to H.R. 3281, offered by Ms. Blunt Rochester of Delaware.
Without objection, the reading of the amendment is dispensed with, and the gentlelady from Delaware is recognized for 5 minutes in support of the amendment.
And thank you, Mr. Chairman. I'm offering this amendment, which I intend to withdraw, that would establish a National Nursing Workforce Center under HRSA and establish a pilot program to support state-based nursing workforce centers that carry out research, planning, and programs to address nursing shortages. The U.S. has experienced cyclical nursing workforce challenges for decades, but none as pronounced as today's challenges. Based on the current state of the nursing workforce in this country, I believe we need a strategy to not only centralize the study and the development of nursing workforce practice and policy, but we also need to better support local entities in addressing state-specific nursing workforce challenges. This amendment will strengthen the nursing workforce and arm states with the tools that they need to implement local solutions based on local conditions. It will also help HRSA expand their evidence base nationally and complement other federal efforts to better understand the nursing workforce. This amendment is based on my bipartisan bicameral legislation, H.R. 2411, the National Nursing Workforce Center Act. I was pleased to see this bill considered at the hearing in April, and I hope that the majority will work with me to include this bill in the next markup. I also want to acknowledge the work of my co-lead, Representative Young Kim, on these efforts, and I'm willing to make changes and address concerns that you may have. And I will withdraw my amendment unless my colleagues wish to weigh in.
Gentlelady yield?
Yes.
I do commit, one of the biggest issues we have, the biggest maybe in healthcare is the nursing shortage. And we definitely need to work together to move forward on that and try to figure out how we can get through this. And so we're certainly willing to work with you. And then I want to also, while I have your time for a second, to thank the gentlelady from California for bringing up Mr. McKeechin and reminding us that how important service is here and how fleeting it can be and how you can do big things. And we need to help continue him as well. So thank you, and we will work with you, and I'll yield back.
Thank you, Mr. Chairman, for the opportunity to work together on this important issue. And thank you also for recognizing my classmate and my friend, Donna McKeechin. Thank you so much, and I yield back.
The gentlelady yields back. With seeking no other discussion, the amendment is withdrawn. Gentlelady withdraws the amendment. Are there any other amendments to the amendment of the nature? Mr. Carter from Georgia, what are you?
Mr. Chairman.
What purpose do you seek recognition?
I seek recognition and offer an amendment,
The clerk will
CART
report.
Georgia 041.
Clerk will report.
Amendment to the amendment in the nature of a substitute to H.R. 3281, offered by Mr. Carter of Georgia. Add at the end of
Without
title.
objection, the reading of the amendment is dispensed with, and the gentleman from Georgia is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Chairman. Mr. Chairman, I'd like to offer this bipartisan amendment that I'm leading with Representative Lisa Blunt Rochester. Let me put into context how powerful PBMs have become. 3 PBMs control 80%, 8 out of 10 of all prescriptions processed in the United States. They own or are owned by insurers and have vertically consolidated their businesses to own everything and everyone between themselves and the patients, including doctors, pharmacies, group purchasing organizations, and more. Yet PBMs do nothing more than process claims. Paper pushers, I like to say. They bring no value to the healthcare system whatsoever. Now, I know pharmaceutical manufacturers need to do a better job with their pricing. I agree. I'll be the first one to admit that. but at least they put money back into research and development. PBMs don't put any money into research and development. All they do is pocket profits. That's why I urge my colleagues to support the Protecting Patients Against PBM Abuses Act. PBMs currently get compensated by charging fees calculated as a percentage of the cost of medicine. This incentivizes PBMs to push the price of medicines higher by blackmailing for formulary access. Blackmailing for formulary access. Telling a pharmaceutical manufacturer that unless you give us a rebate, we are not going to include your medication on our formulary. They choose higher priced medications to put on their formularies. They don't care how much it costs as long as they get a rebate. When PBMs have incentives to favor medicines with higher list prices, it can lead to higher costs for patients who face cost sharing and deductibles and coinsurance that is typically based on list price. It can also mean patients have fewer and higher cost choices when PBMs disfavor generic or lower priced brand competitors. Delaying action any longer results in increased costs for patients. My patients never ask me to dispense them a medication with the highest priced medicine. Why do the PBMs think that's what's best for patients? Because they're getting a higher rebate from it. That's why they do it. By delinking administrative fees paid to PBMs from the price of medicines, this proposal will help to correct this misaligned incentives and bring relief to patients to the pharmacy counter. Representative Lisa Blunt-Rochester and I are proposing this bipartisan bill that will help patients afford their medicine and protect them from harmful PBM practices. There's no silver bullet to fix a system that's taken decades to get so convoluted and manipulated, but I greatly appreciate the work of this committee and so many of my colleagues to start to rein in these PBM tactics and put patients first. I understand that the Protecting Patients Against PBM Abuses Act is not on the agenda today, but I would like to work with the committee to ensure that it is ready for consideration at a future markup. Thank you, Mr. Chairman, and if anyone wants to comment, I'll be glad to yield.
Seeing no, it's your time, I'm sorry. Gentleman yields back.
I yield back.
The gentleman yields back. Is anyone seeking recognition? What purpose does the gentlelady from Delaware seek recognition?
Mr. Chairman, I move to strike the last word.
Gentlelady is recognized for 5 minutes.
Mr. Chairman, I want to thank Congressman Buddy Carter, my good friend, for the theme that he established here, which is putting patients first. I want to also thank you for calling this amendment, and I want to speak in support of the policies put forth. This amendment would further address PBM's opaque and overly confusing role in the drug supply chain. It will reduce perverse incentives to ensure that PBM business models benefit patients and lower cost of medications at the pharmacy counter and through the entire supply chain. This amendment is critical because high drug prices in the U.S. are harmful to the health and economic security of patients across our country. Last year, 5 million Medicare beneficiaries, people generally on modest fixed incomes, struggle to afford their prescription drugs. That is why last Congress we took action and passed the historic Inflation Reduction Act to reduce prescription drug costs by allowing Medicare to negotiate prices with manufacturers, implementing inflation rebates and capping out-of-pocket costs. This amendment addresses another part of the drug supply chains, PBMs. This amendment will rein in adverse PBM practices and help contain the cost of soaring drug prices by, one, delinking the connection between drug prices and PBM revenues. This will help reduce the incentives that PBMs may have to steer patients toward higher cost drugs. Two, allowing PBMs to earn revenues through transparent, flat administrative fees, which will ensure that PBMs receive fair market value for their actual services that they perform. Three, promoting reasonable and understandable PBM data transparency so that patients, plans, and other stakeholders can see where their hard-earned dollars are going. And four, preserving patient access to the pharmacy of their choice. These are bipartisan, bicameral, and in my opinion, common sense policies that will help ensure that PBMs are working in the best interests of their clients and the American people. I think these policies warrant further attention from our committee, and I look forward to working with the committee and particularly with my co-lead, co-partner in this effort, Representative Buddy Carter, and I look forward to continuing the conversation. Thank you, Mr. Chairman, and I yield back.
Thank you. The gentlelady yields back. Seeing no further discussion on the amendment, the gentleman withdraws his amendment. So the amendment is withdrawn. Are there any other amendments being offered? Seeing none, before the committee will be action on the amendment in the nature of a substitute. If there's no further discussion, there will be a vote occur on the amendment in the nature of a substitute. All in favor will say aye. Aye. All opposed will say nay. The ayes have it. The amendment in the nature of substitute is adopted. Now before the committee will be vote on the passage of HR, I gotta get the right one this time, HR 3281 as amended. There will be a roll call vote is requested. The clerk will call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Mr. Burgess. Mr. Burgess votes aye. Mr. Latta. Mr. Latta votes aye. Mr. Griffith. Mr. Griffith votes aye. Mr. Bilirakis. Mr. Bilirakis votes aye. Mr. Johnson. Mr. Johnson votes aye. Mr. Bouchon. Mr. Bouchon votes aye. Mr. Hudson. Mr. Carter. Mr. Carter votes aye. Mr. Dunn. Mr. Pence. Mr. Pence votes aye. Mr. Crenshaw. Mr. Crenshaw votes aye. Mr. Joyce. Ms. Harshbarger. Ms. Harshbarger votes aye. Ms. Miller-Meeks. Mr. Obernolte. Mr. Obernolte votes aye. Chair Rodgers. Chair Rodgers votes aye. Ms. Eshoo.
Aye.
Ms. Eshoo votes aye. Mr. Sarbanes. Mr. Sarbanes votes aye. Mr. Cardenas. Mr. Cardenas votes aye. Mr. Ruiz. Mr. Ruiz votes aye. Ms. Dingle. Ms. Dingle votes aye. Ms. Custer. Ms. Custer votes aye. Ms. Kelly.
Aye.
Ms. Kelly votes aye. Ms. Bodegon. Ms. Blount-Rochester. Ms. Blount-Rochester votes aye. Ms. Craig. Ms. Craig votes aye. Ms. Schreier. Ms. Schreier votes aye. Mr. Hand. Mr. Hand votes aye. Mr. Pallone. Mr. Pallone.
Frank? The bill?
Mr. Pallone.
The bill, the transparency bill.
Mr. Pallone votes aye.
How is Dr. Dunn recorded?
Mr. Dunn is not recorded. Mr. Dunn votes aye.
Anyone else seeking recognition to record? You have anybody coming back? Everybody, no one seeing recognition? The clerk shall report.
Chair Guthrie, on that vote, we have 26 ayes and 0 nays.
With 26 ayes and 0 nays? How is Dr. Joyce recorded?
Dr. Joyce is not recorded. Joyce votes aye.
Anyone else seeking recognition or vote? Seeing none, with 27 yeas and 0 nays, the bill is, as amended, is forwarded to the full committee.
Mr. Chairman, is Mr. Walden recorded? Great to see you.
He comes to look at his picture. Thank you. The bill is reported to the full committee as amended. So the chair calls up HR 2666 and asks the clerk to report.
HR 2666, a bill to amend Title 19 of the Social Security Act to codify value-based purchasing arrangements under...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any time. So ordered. Does anyone seek to be recognized on the bill? I have an amendment, so I'll offer amendment. Okay. I have an amendment at the desk. An amendment in the nature of a substitute. Clerk shall report the amendment.
Amendment in the nature of a substitute to H.R. 2666, offered by Mr. Guthrie. Strike all after the enacting clause.
Without objection, the reading of the amendment is dispensed with, and I'm recognized for 5 minutes in support of my amendment. The Bipartisan MVP Act, which I'm co-leading with ranking member of the subcommittee, Representative Eshoo, will build off the work both the Trump and Biden administrations have done to provide access to life-saving curative cell and gene therapies to patients on Medicaid. Currently, the Medicaid system does not have flexibility to pay for higher-cost curative one-time treatments such as the cell and gene therapies. Medicaid programs operate on an annual budget and need more flexibility to help ensure states can pay for patients on Medicaid to gain access to these therapies without further crowding out other important state priorities. Massachusetts' recent announcement is an example of trade-offs states contemplate when drug coverage in their Medicaid program. MassHealth, the state's Medicaid program, recently said it would stop paying for almost a dozen drugs approved or pending approval by the FBI with annual costs of over $100,000, including CAR-T cancer therapies and a therapy used to cure a rare vision disorder in children that can lead to complete blindness. The innovation coming in the next 5 years is game-changing, including potential one-time cures for rare diseases, sickle cell, and hemophilia. Promising potentially creative treatments underscore the need for action to address the challenges posed by the current regulatory environment. The MVP Act will ultimately better align incentives in the healthcare system for innovation and cures for rare diseases. Under the MVP Act, states would no longer have to choose between completely limited access to these therapies or potentially increasing what they spend on Medicaid by raising taxes or cutting other programs. The legislation would specifically permit states to enter value-based agreements for these therapies, ensure they are not on hook for paying for treatments that are ineffective in certain patients. Further, this legislation allows states to see long-term savings if a one-time therapy appears incurable in a high-cost condition. It also allows them to enter agreements to pay over time. I once again want to thank Representative Eshoo and other colleagues on the subcommittee, Dr. Joyce and Miller Meeks, and Representative Auchincloss for leading on this important issue with me. And I would like to thank Representative Bilirakis, Dunn, and Slawell for joining us in supporting our efforts. It should be noted that the amended version before us today reflects input from Centers for Medicare and Medicaid Services. We will continue working with the agency to incorporate any additional feedback they have to ultimately get this bill across the finish line, which CMS Administrator Brooks LaSure testified as an objective. And I think all of us have groups that come to see us daily with these miracle cures. I remember sitting just a few years back with Dr. Francis Collins when he was head of NIH, and so we're on the verge of curing sickle cell anemia and hemophilia and other conditions. And if we can, and this is Medicaid, so the access to these drugs through the Medicaid program, we need to absolutely, in conditions, make sure it's available, where states have the ability to sit down with the person providing the therapy, and they have skin in the game too. If the therapy doesn't do the cure and doesn't save money for the state in the long run, then they have skin in the game as well. But it's one-time or heavy upfront costs that we can cure people. And so that's the most important thing. But the other thing is if somebody has a chronic disease, they're going to cost the system money over time. So the idea is that we spend money up front, we save money over time, but much more important, we save people from the ravages of diseases like sickle cell anemia and it is sickle cell. And it is just important for us to have the opportunity to do this. I'm excited about it because it will continue to spur more and more gene therapies. It's amazing what mapping the genome did. It unleashed the genome for human history and all the scientists to work on. But it also has led to therapies, and the therapies are expensive. And I wish they weren't so expensive, but if we don't pay for them, we're not going to get them. And we certainly want people in these disease states and categories to have coverage. And that's what this bill does. And it's a bipartisan effort. We have worked hard to get there. Bipartisan effort before the last couple of Congresses. I know there's a bipartisan group in the Senate forming for this too. So we really believe we can get this across the finish line. If there's work that needs to be done to get there, we're going to work to get there. But we absolutely want this bill to be on the president's desk this year. That's my goal. I think it's the committee's goal, and it certainly is going to be my effort. So I will yield back, and the chair recognizes the gentlelady from California for 5 minutes. You speak on, you want recognition, right? Just speak on the bill, on the amendment.
Thank you, Mr. Chairman. As has been stated, cell and gene therapies have the potential to treat or even cure diseases such as sickle cell disease, hemophilia, cancer, or type 1 diabetes, but they come at a very high cost. To increase patient access while lowering costs, insurance companies and state Medicaid plans are considering new value-based payments for specialty drugs that are tied to patient outcomes. That's what's different in this. That's really kind of the center of this issue. And if the drug doesn't work for a patient, then the manufacturer could agree to completely refund the cost of the drug. So if it doesn't work, then it's zero. The existing statutory drug pricing measures are over 30 years old. So I think that we might be on the threshold of making a change here, and I think that it's needed. And it was never meant, what's in place, it was never meant to account for a potential zero drug price, making it difficult for value-based payments to lower costs. Our legislation, the MVP Act, updates the law for 3 key measures: best price, average manufacturer price, and average sales price. So that Medicaid can benefit from value-based payments. On Medicaid best price, the policy requires drug manufacturers to give Medicaid programs the lowest price they give commercial payers. If a drug is zero because it didn't work for a single patient in a single plan, then that zero would become the Medicaid payment nationwide. So that has to be addressed. And to address this, CMS issued rulemaking to allow manufacturers to report the multiple best prices available in value-based arrangements. The rule estimated $228 million in state and federal savings over 3 years. Our legislation codifies this rulemaking so that plans and manufacturers can trust the flexibility will be available as they begin the long-term planning for these types of payments. Now, key to the legislation is that Medicaid plans can still get the best deal offered to the commercial market. And to do that, our bill has the following guardrails. First, manufacturers have to offer the same value-based payment arrangement to Medicaid that they do to commercial insurers. Secondly, the value-based payments are voluntary. If they're not a good deal or too burdensome, then commercial payers can insist on traditional discounts in exchange for coverage, and Medicaid plans can choose that traditional best price over a value-based payment. Third, manufacturers will be subject to enforcement actions, such as civil monetary penalties for false reporting of pricing information. If CMS needs to revise the best price rule to address unintended consequences, then they'll be able to amend the rule and its definition of value-based payments under the law. The Biden administration recognizes the promise of value-based payments for gene therapy, saying they will improve patient access and reduce costs while avoiding stringent prior authorization that keeps Medicaid patients from getting the cutting-edge care that they deserve. At our recent hearing with the CMS administrator, she said that, quote, CMS is very interested in helping states pursue outcomes-based options for Medicaid. We also heard testimony from the Leukemia and Lymphoma Society, who said our legislation, the MVP Act, will promote patient access to treatments. So I'm sure each one of you had just followed every word I've said But I think that this is common sense. It allows for a change that needs to be made. Our constituents benefit from it. This hasn't been updated for 30 years. I think we can handle a change after having something in place for 30 years. And most importantly, to be able to best address the cell and gene therapies that have the potential to treat or even cure diseases like sickle cell disease, hemophilia, cancer, or type 1 diabetes. I think that really is the greatest motivator of all. So thank you, Mr. Chairman, and I yield back. Pleasure
Thank
to
you.
work with you on this.
And I appreciate working with you as well. Is there any further discussion? The gentleman from New Jersey, what purpose you seek recognition?
Strike the last word and express my concerns about the bill.
The gentleman is recognized for 5 minutes.
Thank you, and I want to assure you, as well as Ms. Escher, that I tried to follow every word that you said. But even though I still have concerns, I appreciate the sponsor's intent, but I do fear this bill will not lower the cost of prescription drugs and could in fact increase drug costs to state Medicaid programs and the federal government. And for these reasons, I can't support the bill and urge my colleagues to join me in voting no. Now, the MVP Act would permanently codify in statute a Trump-era regulation that effectively changed the definition of best price in Medicaid, supposedly in an effort to support the adoption of value-based payment models in the private market. And as my colleagues know, the Medicaid best price policy ensures that state Medicaid programs are able to obtain discounts on drugs equal to the best discount available on the private market. Nonpartisan experts expressed concerns that the regulation and by extension the legislation before us would create a loophole in the Medicaid program that drug companies could exploit to evade the best price protection and allowing them to pay lower rebates to Medicaid and increase the cost of drugs. So the bipartisan National Association of Medicaid Directors said that the policy, and I quote, would greatly favor drug manufacturers over states, undermine best price protections that ensure the sustainability of Medicaid pharmacy budgets, and place substantial strain on state administrative resources. Similarly, the nonpartisan Medicaid and CHIP Payment and Access Commission, or MACPAC, said the policy is of, quote, questionable benefit to Medicaid, and expressed concerns that the policy could create a loophole such that the primary purpose drug manufacturers may enter into these payment models would be to lower their Medicaid drug rebates. MACPAC also raised concerns about the administrative complexity of these arrangements and was skeptical that the policy would increase the availability of value-based payment models. And then we have the Georgetown University Center on Children and Families, which called the policy, and I quote, seriously flawed, and said that the policy would essentially gut best price. So given these comments, I am concerned that the regulation could weaken Medicaid best price protections and increase costs for states and the federal government. I don't think we should double down on the approach of the Trump-era regulation by permanently codifying it into federal law. I would actually encourage the Biden administration to reconsider the merits of the regulation and consider repealing it. So again, I appreciate my colleagues' efforts to make prescription drugs more affordable. I know everybody's motivated by that today, but I just don't think this is the right approach and don't support the bill and would urge members to join me in voting no. And with that, Mr. Chairman, I yield back.
The gentleman yields back. Is there any further discussion? Dr.
Mr. Chair, I move to strike the last
The
word.
gentleman is recognized for 5 minutes.
Thank you, Mr. Chairman. I would like to offer my support of H.R. 2666, the MVP Act, of which I was proud to be an original co-sponsor when it was introduced by Chairman Guthrie, along with Ranking Member Eshoo earlier this year. I would also like to thank the committee for advancing this critical legislation here today. Mr. Chairman, as a doctor, I share your enthusiasm for the support for gene therapies because we finally have the potential to treat and perhaps cure genetic disorders, which are at the root cause, providing long-term, if not permanent benefits and overall improving the quality of life for patients. Because many of these treatments are curative, the current reimbursement system fails to reflect the value of these therapies, nor does it offer states the needed flexibility to provide adequate coverage for those who are under Medicaid. The bill before us today would provide regulatory certainty for every state by codifying Medicaid rules that permit multiple reporting of best prices to help states enter value-based payment arrangements to pay for the curative cell and gene therapies over time. These value-based purchasing arrangements for gene therapy products ensure that the price of gene therapy is based on its clinical outcomes and the value it provides to patients and to the healthcare system. The MVP Act, like CMS' multiple best price rule, would allow manufacturers to submit multiple best prices to state Medicaid programs and also allow state Medicaid programs to voluntarily enter the value-based purchasing arrangements with drug manufacturers for these therapies. This bill would ensure that Medicaid patients have the same access to game-changing gene therapies and the long-term benefits and improved quality of life that they provide as those patients with private insurance. I urge all of my colleagues to participate in the adoption of this important legislation, and I yield the balance of my time.
The gentleman yield back, yield to me.
I yield, Mr. Chairman.
I appreciate that, and I appreciate my good friend from New Jersey, but, you know, I know we talked about these being Trump-era regulations, but we also need to, the second part of that's continued by the Biden administration as well. So both administrations see value in this. I used to be a state legislator, and we focus on Medicaid and annual budgets, and you have one-time big hits from state budgets on these types of treatments that really change people's lives, and it allows the states to enter an agreement. Nobody's forcing them to. It allows them to, so they can take care of the citizens of their state in a way. And as we all know, and the ranking member said, if the treatment these can be set up where if the treatment doesn't do what it's supposed to do and save costs over time, then the pharmaceutical company has skin in the game, and they can not be paid for it or have to reimburse for it. So we think that's important, and it has both administrations are supportive of this. And if the gentleman from Pennsylvania let me take his time and yield to the gentlelady from California, I'll do so. Thanks.
Absolutely.
Thank you, Mr. Chairman. I want to address a couple of things that Mr. Pallone stated. And the issue of Medicaid directors and their response to this issue. The National Association of Medicaid Directors and MACPAC raised concerns about the proposed rule, but many of their comments, and this is very important, were addressed by the final rule and the Biden administration's March 22 guidance. On this issue of where the administration is, the Biden administration supports value-based, this entire issue of value-based, they have kept the rule. I mean, if they didn't support it, they wouldn't have kept the rule. And in fact, they have now issued guidance on the rule. So for my colleagues on this side of the aisle, I think that what Mr. Pallone has raised would, you would, with legitimacy, I think, find it chilling, except it's not so. And so I wanted to speak to that, and I yield back. Thank you.
Gentleman from Pennsylvania yields back. Gentleman yields back. Is there any other discussion on the amendment? The gentlelady from Delaware, what purpose you seek recognition?
I move to strike the last word.
The gentlelady is recognized for 5 minutes.
Thank you, Mr. Chairman. And I guess I just want to clarify, I'm not necessarily opposed to this policy, and I think there's strong support for all of us for advancing drug innovation and promoting the development of life-saving cures like sickle cell and like cell and gene therapy. I mean, this is something personal for many of us. But given the concerns that the ranking member outlined, I'm struggling to understand why we can't wait to see how the rule is implemented and if the concerns that the stakeholders have play out or don't play out. So I just put that forward to say, at this point, I intend to vote no, but I open the door for more discussion about, and I yield the time if someone wants to. It's my understanding this already has the force of law. Yes,
The concern is, as you said, we know that the Trump administration put these forth, the Biden administration has agreed, but a lot of times in rules, new administrations come and go, and these are value-based agreements over time, and so the certainty of law is what we're trying to get to for these companies to make these agreements. So I'll yield back to you.
So just,
I would just add just another layer to it, and that these value-based agreements are carried out by stakeholders. Stakeholders need to know how stable the situation is. So it takes time. It takes time. So, but the issue of this being just a Trump administration issue, and now it's being revived or spoken to or changed or whatever, that the Biden administration is not for, the facts simply don't support that. Yeah. And we need to advance this for the very reason that you said you have a personal stake in it, and that is, you know, the diseases. So I don't think we should be paying for something that doesn't work.
so just reclaiming my time. I'm a big supporter of value-based arrangements. This is important, but doesn't this already have the force of law? Was, I guess, my question.
Gentlelady yields back. Did you, was that a question you want me to add?
Yes, please.
Oh, okay, I'm sorry. So it's, my understanding is that it's a rule that could be, we're giving it the force of law. We're putting it in law, not just the force of law. So we're giving certainty. Of course, any Congress could change in the future. I understand, you know, how hard it is to change things. And when Congress does and puts in place that these companies can enter these value-based agreements with more stability and more rigidness and going forward.
Mr. Chairman, could I get a response from council as well on the question?
What was your question? Yes, absolutely. What's the question?
Doesn't this currently have the force of law?
In regards to the best price policies in the rule, it would already have the force of law. There are additional amendments made by the legislation to value-based payment arrangements as well.
Thank you. Mr. Chairman, I yield back.
Gentlelady yields back. Is there any other discussion on the amendment? Seeing none, if there's no further discussion, the vote occurs on the amendment in the nature of a substitute. All those in favor shall signify by saying aye. Aye. All opposed, no. No. The ayes have it. And on the amendment or on the final bill? Final bill, okay, yes, we're going to roll call on the final bill. Okay, perfect. So the amendment is agreed to. So you withdraw your request for the roll call on the amendment. Agreement is agreed to. So we'll move to the final. Here we are. So now before us is House Resolution. Lost my place here, kind of taking notes in this debate. House Resolution House Representative 266 is before us. The motion is to move House HR 266, let me get the right number right, 2666 to the full committee as amended, and the roll call being asked for, the clerk will call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Mr. Burgess. Mr. Burgess votes aye. Mr. Latta. Mr. Latta votes aye. Mr. Griffith. Mr. Griffith votes aye. Mr. Bilirakis. Mr. Bilirakis votes aye. Mr. Johnson. Mr. Johnson votes aye. Mr. Bouchon. Mr. Bouchon votes aye. Mr. Hudson. Mr. Carter. Mr. Dunn. Mr. Dunn votes aye. Mr. Pence. Mr. Pence votes aye. Mr. Crenshaw. Mr. Crenshaw votes aye. Mr. Joyce. Mr. Joyce votes aye. Ms. Harshbarger. Ms. Harshbarger votes aye. Ms. Billy Meeks. Mr. Obernolte. Mr. Obernolte votes aye. Chair Rodgers. Ms. Eshoo. Ms. Eshoo votes aye. Mr. Sarbanes. Mr. Sarbanes votes aye. Mr. Cardenas. Mr. Ruiz. Your record is aye. Mr. Sarbanes is off aye and on no. Mr. Cardenas. Mr. Ruiz. Mr. Ruiz votes no. Ms. Dingle. Ms. Dingle votes no. Ms. Custer. Ms. Custer votes no. Ms. Kelly.
No.
Ms. Kelly votes no. Ms. Badagan. Ms. Badagan votes no. Ms. Blount-Rochester. Ms. Blount-Rochester votes no. Ms. Craig. Ms. Craig votes no. Ms. Schreier. Ms. Schreier votes no. Mr. Hand. Mr. Hand votes no. Mr. Pallone. Mr. Pallone votes no.
Anyone else seeking recognition of the chair? Chair Ryhouse, Chair Rodgers recorded.
Chair Rodgers is not recorded. Chair Rodgers votes aye.
How's Mr. Cardenas recorded?
Mr. Cardenas is not recorded. Mr. Cardenas votes aye.
Anyone else seeking recognition to be recorded? See the door opening there? No, none. The clerk will report.
Chair Guthrie, on that vote, we have 16 ayes and 11 noes.
With 16 yeas and 11 nays, the bill as amended is forwarded to the full committee. The chair calls up the chair calls up HR 3285 and asks the clerk to report.
HR 3285, a bill to establish patient protections with respect to highly rebated drugs. Be it enacted.
Objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek to be recognized on the bill?
Mr. Chairman,
For what question does the gentleman from Virginia seek recognition?
I seek recognition to speak to the bill.
The gentleman is recognized for 5 minutes.
I thank you, Mr. Chairman. We buy health insurance so that if we get sick, we are not financially devastated by the high costs associated with the health care we receive. That said, oftentimes costs are just too high. With respect to prescription drugs, we have heard in our hearings that the so-called incentives from PBMs to insurers can actually lead to patients paying higher prices for certain medicines. It can even mean a patient could, in some cases, pay more for a medicine than the insurance company with whom they have coverage. Using competition to lower prices makes sense, but using competition to raise prices by limiting access to the marketplace is unconscionable. That's why I introduced the Fairness for Patient Medications Act to ensure that insurance companies and PBMs cannot charge patients more than the price they negotiate themselves for certain drugs. Under my bill, the Secretary of HHS will use existing reporting data to certify a highly rebated drug as a drug whose rebates discounts equal 50% or more than spending on the drug. If the drug is highly rebated, a patient would not be required to pay more than the insurance company is paying for the drug from the previous year once all the discounts are accounted for. For highly rebated drugs, patients won't pay more than the insurer pays for the drug. This is common sense legislation. Now you got to follow the bouncing ball because it does get a little complicated at times. One, PBMs can pit manufacturers against one another to see who will offer them the largest rebates for competing medicines. The winners get preferred access to patients enrolled in health insurance plans serviced by those PBMs. So, manufacturers are rewarded with market access by making their list prices for a medication higher. Higher prices on those medications allow the manufacturers to give the PBMs higher rebates so that they can say, look at the good deal we're getting you. 3, and following that bouncing ball, but even with the rebates, the PBMs are often paid a percentage of the list price. So even with the rebates, because the list price is now higher, the PBM makes more money. And
even though the final price of these drugs after rebates may be significantly less than the list price, to some patients, the list price actually matters. Some health insurance plans actually base what a patient pays at a pharmacy as a percentage of the drug's list price, and some still pay cash. This bill will ensure that patients receive the savings from these rebates and not the PBMs. During our legislative hearing on April 26th, the Pharmaceutical Care Management Association, that would be the trade association for PBMs, told me that they actually were aware that sometimes patients pay more than the price the insurers are charged in certain circumstances. As an example, according to one estimate, a 5 milligram oral tablet of Eliquis, a common blood clot medicine or drug, has an estimated net price after all the rebates of $73.14. This should be the maximum price that a patient has to pay then. Instead, the drug has an estimated retail price of $387.39. This is the cost the insurers can charge because of a rebate system where middlemen, PBMs, use this system to raise list prices of drugs. In other words, if your copay were 20% of the list price, you could actually pay more in so-called copay than the medicine costs your insurer. This bill would ensure a patient with insurance would not pay more than the net price paid by their insurance company. This bill is a matter of simple fairness. It is, as my colleague from Georgia said earlier, there is no silver bullet on dealing with PBMs. This is just one small step. But I hope that we vote on this bill favorably today and get it out of the subcommittee. If we need to continue working with CMS, that's fine, and we can certainly work with my friends across the aisle to get the bill into a good spot to fully address the issue at hand, but we must deal with this issue where people are taking advantage of our constituents to put cash in their pocket with no gain. I yield back.
The gentleman yields back. Is there further discussion on the bill? The gentleman from New Jersey is recognized for 5 minutes.
Thank you, Mr. Chairman. I move to strike the last word. I'm very concerned about the rising cost of prescription drugs, as we all are. Americans pay more for prescription drugs than any other country in the world. A Kaiser Family Foundation poll found that 1 in 4 Americans who take prescription medications find them to be unaffordable, and nearly 1 in 3 adults in the U.S. report not taking their medicines as prescribed because of the costs. And I believe we should move forward policies that directly lower the cost of prescription drugs for patients. And so I have concerns about this bill that it could potentially increase costs to some patients and raise premiums. The Congressional Budget Office has provided preliminary feedback that this bill could have a cost to the federal government. If that is the case, it may also raise premiums for American families. And we're still waiting for a final estimate from CBO. I also have concerns with how the policy will be implemented given the technical analysis provided by CMS and experts that has not been incorporated yet. So at this time, I'm not able to support the policy. However, I look forward to obtaining a final estimate from CBO, and we'll continue to examine the impact of this policy on drug costs, on insurance premiums, and on patient access to prescription drugs. And with that, Mr. Chairman, I yield back.
The gentleman yields back. Is there any further discussion? Any amendments to the bill? See no further discussion, no amendments to the bill. The question now occurs on forward in H.R. 3285 to the full committee. All those in favor say aye. Aye. All opposed, no. In the opinion of the chair, the ayes have it, and the bill is agreed to. The chair calls up H.R. 3284 and asks the clerk to report.
H.R. 3284, a bill to require the Secretary of Health and Human Services to submit an annual report on the impact of certain Medicare regulations on provider and payer consolidation. Be it enacted by the...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? For what purpose does the gentleman from Texas seek recognition?
I seek to speak on the bill.
The gentleman is recognized for 5 minutes.
Thank you, Mr. Chair. Earlier in the markup, I mentioned HR 3284, so-called Compete Act, which does require the Secretary of HHS to consider within the annual rulemaking process the effect of regulatory changes to certain Medicare payment systems on provider and payer consolidation. Regulators should understand the full effect of horizontal and vertical consolidation among providers and payers. Our healthcare system demands a comprehensive examination to eliminate anti-competitive practices. This legislation will empower the Department of Health and Human Services with a thorough understanding of the implications of new payment proposals, fostering a climate of competition and shielding American patients from exorbitant health care costs. By doing so, we are both safeguarding patient autonomy and patient financial well-being. Americans should also understand the full implications of rulemaking beyond the cost of the rule, and they should be aware of actions being taken to further healthcare consolidation. So I'm glad to see HR 3284 move forward. I hope to see changes that will further inform future policy and future rulemaking. And Mr. Chairman, I'm prepared to yield back.
The gentleman yields back. Is anyone else seeking discussion on the bill? The gentleman from Florida, what purpose is the gentleman from Florida seek recognition?
To strike the last word.
Gentleman's recognized for 5 minutes.
Thank you. I want to urge my strong support for H.R. 3284, the Providers and Payers Compete Act, which will require HHS to consider the effects of consolidation as part of its annual rulemaking process in Medicare. I commend and thank Representative Burgess for his leadership on this bill. I'm grateful to be included as an original co-sponsor. As mentioned earlier, our committee has held hearings where we heard concerns about the lack of competition in healthcare. I've been particularly concerned that annual rulemaking from CMS, such as Medicare's physician fee schedule and hospital outpatient prospective payment system rules, have inadvertently contributed and worsened consolidation trends. For example, I led a bipartisan letter signed by 75 members last Congress to CMS expressing concern about the physician fee schedules policy to update the clinical labor policy. While it was helpful for many providers, unfortunately, due to budget neutrality rules, this policy meant significant cuts to office-based specialists that historically have competed well in outpatient settings, often providing care in their respective communities at lower rates than hospitals. Unfortunately, these PFS cuts have meant many freestanding clinics have closed their practices and doctors have been incentivized to join larger conglomerate, I know how to say it, health systems due to reimbursement trends. The Providers and Payers Compete Act would ensure that CMS is considering these in its analysis of its annual rulemaking process. This analysis includes both horizontal and vertical consolidation, and it is not only limited to Part B, but also includes Part C and D as well, meaning insurance companies and Medicare Advantage organizations who have also continued to consolidate in the healthcare system, particularly with the vertical integration of PBMs, fall under this HHS impact analysis as well. Patients and policymakers need to better understand the costs and implications of annual rulemaking that impact the Medicare program. Our legislation, led by the doctor, will ensure this happens as part of the agency's public comment and regulatory process on a yearly basis. This is a common sense proposal, and I thank Dr. Burgess for his work on this issue, and I urge my colleagues to join me in support, and I yield back the balance of my time. Thank you.
The gentleman yields back. Anyone seeking discussion for, what's the purpose of the gentlelady from Michigan? Seek recognition?
Mr. Chairman, I move to strike the last word.
Gentlelady is recognized.
Thank you, Chairman Guthrie and Ranking Member Eshoo, for including the Provider and Payers Compete Act at today's subcommittee markup. And thank you, Rep. Burgess, for your partnership and leadership on this very important issue. We know provider consolidation suppresses competition. Several studies have identified that the primary effect of consolidation is to increase prices and by significant amounts as market concentration rises. Provider consolidation not only drives up prices, but it can also undermine patients' quality of care. It's critical we understand the impact that provider payment rules may have on further consolidating the healthcare system. That's why I'm proud to join Rep. Burgess in introducing the Providers and Payers Compete Act. The legislation will require the U.S. Department of Health and Human Services, as part of any rulemaking process that could result in provider or payer consolidation, to have a public comment period to better understand the impact on consolidation and let the patient have input. In addition, it would require HHS to submit an annual report to Congress detailing the impact in the aggregate on provider and payer consolidation from regulations implemented the prior year. Taken together, this bill will help HHS better understand the impact of Medicare regulations and hopefully reduce consolidation. I urge all of my colleagues to support it. Thank you, Mr. Chairman, and I yield back.
The gentlelady yields back, and is there further discussion? Seeing none, the question now occurs on forwarding H.R. 3284 to the full committee. All those in favor will say aye. Those opposed say no. The clerk will call the roll.
Chair Guthrie.
Yeah, aye.
Chair Guthrie votes aye. Mr. Burgess. Mr. Burgess votes aye. Mr. Latta. Mr. Latta votes aye. Mr. Griffith. Mr. Griffith votes aye. Mr. Bilirakis. Mr. Bilirakis votes aye. Mr. Johnson. Mr. Johnson votes aye. Mr. Bouchon. Mr. Bouchon votes aye. Mr. Hudson. Mr. Carter. Mr. Carter votes aye. Mr. Dunn. Mr. Pence. Mr. Pence votes aye. Mr. Crenshaw. Mr. Joyce. Mr. Crenshaw votes aye. Mr. Joyce. Mr. Joyce votes aye. Ms. Harshbarger. Ms. Harshbarger votes aye. Ms. Miller-Meeks. Ms. Miller-Meeks votes aye. Mr. Obernolte. Mr. Obernolte votes aye. Chair Rodgers. Chair Rodgers votes aye. Ms. Eshoo. Ms. Eshoo votes aye. Mr. Sarbanes. Mr. Cardenas. Mr. Cardenas votes aye. Mr. Ruiz. Mr. Ruiz votes aye. Ms. Dingle. Ms. Dingle votes aye. Ms. Custer. Ms. Custer votes aye. Ms. Kelly.
Aye.
Ms. Kelly votes aye. Ms. Badagon. Ms. Badagon votes aye. Ms. Blunt-Rochester. Ms. Blunt-Rochester votes aye. Ms. Craig. Ms. Craig votes aye. Ms. Schreier. Ms. Strahan. Ms. Strahan votes aye. Mr. Pallone. Mr. Pallone votes aye.
Anyone seeking recognition for the, how is Dr. Dunn recorded?
Dr. Dunn is not recorded. Dr. Dunn votes aye.
Anyone else? Seeing none, the clerk will report.
Chair Guthrie, on that vote, we have 27 ayes and 0 nays.
With 27 ayes and 0 nays, the ayes have it, and the bill is agreed to. Here it is. Right there. Start right there.
Got it. Chair calls up H.R. 3290 and asks the clerk to report.
H.R. 3290, a bill to amend Title III of the Public Health Service Act to ensure transparency and oversight of the 340B drug discount program. Be it enacted by the
Without
Senate-
objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any time. So ordered. Does anyone seek recognition on the bill? Chair Rodgers, want to do the first? I recognize myself for 5 minutes to speak on the bill. The 340B drug pricing program is an important tool that helps hospitals and other covered entities meet the healthcare needs of low-income and uninsured patients. 340B covered entities are able to purchase drugs for patients of their facilities at substantial discounts. However, if you ask me to tell you what this program actually looks like at the facility level and what covered entities do with their savings, I truly couldn't tell you at this point. And that should be a concern to everyone. I want to be very, very clear. I'm a supporter of the 340B program. I know firsthand from talking to hospitals in my district how important the program is. For example, a hospital in a rural county in my district has told me they couldn't provide many of the services they provide without the 340B program. But the only way for us as lawmakers to understand what this program looks like for our constituents is to go to each hospital and ask them for their data. This is not my opinion. That's the assessment of the GAO in multiple reports. It's also the assessment of HHS Secretary Becerra, who told this committee in March that the program, and I quote, doesn't have the transparency we need, and of the Biden administration, whose budget for this year called for greater transparency and auditing of the program. This program has operated for decades without enough transparency, all the while growing at exponential rates in an unchecked fashion. For example, from 2000 to 2020, the number of covered entities has grown from 8,100 to nearly 50,000, with an estimated discounted purchases through the program going from $4 billion in 2007-2009 to $43.9 billion in 2021. According to HRSA, this level of 340B sales represented approximately 7.2% of the overall U.S. drug market in 2021. So we're not talking about a small or insignificant program. And unfortunately, we know that the 340B program can be a lucrative business deal for some participants and further drive us towards consolidation in the healthcare system. Take, for example, a hospital system who the New York Times profiled in September of last year. According to the New York Times, the hospital system has potentially exploited the program by acquiring providers across a massive footprint to maximize savings from the program to increase profits while decreasing services in their inner-city facility. However, I don't know if that's true or not because of lack of transparency. Transparency will not only give all of us the confidence that the program is being properly utilized, but will help institutions defend themselves against such charges if they are doing the right thing. I hear all the time from providers across the country who are repeatedly barraged by hospital systems trying to acquire them to realize the 340B savings. If we care about competition and consolidation in the healthcare sector, we deserve to know how much in savings is generated by this program at each facility and at each facility that a hospital system may acquire. And to those who may argue that these requirements are burdensome, I'd ask you to look to the grantees in this program, like the Ryan White HIV/AIDS clinics, federally qualified healthcare centers, Indian health centers, the Bluck Dyke lung clinics, who do have some transparency requirements to account for how they use the 340B program and have specific requirements on how to reinvest those savings into their patients. It can be done. However, according to HRSA, more than 75% of 340B covered entity purchases were made by disproportionate share or DISH hospitals in fiscal year 2021. HR 3290 simply would require program participants to provide some basic transparency information to HRSA about the patients who are being served by the 340B program. Requiring greater transparency of how covered entities use 340B dollars is an important step, and I'm glad that this legislation will give us a better handle on how these dollars are being used. As we move the bill through the process and potentially look at other reforms related to the 340B program, I do think we should work to make the program as transparent as we possibly can. Full transparency into all 340B participants will ensure Congress and HHS have a true sense of how billions of dollars of discounts are being spent across the program and that it's going to benefit the patients. I urge support for this legislation. I yield back. Anyone else seek recognition? Mr. Pallone, recognized for 5 minutes.
Thank you, Mr. Chairman. None of the, I move to strike the last word and speak in opposition. Mr. Chairman.
Gentleman's recognized.
Thank you, Mr. Chairman. None of us are opposed to transparency in the 340B program, and I've been a longtime supporter of increased program integrity to ensure that covered entities are able to stretch scarce federal resources to reach more eligible patients and provide more comprehensive services, which is the stated mission of the 340B program. However, I am concerned that this bill will add additional burdens to covered entities without providing additional clarity into how the program is actually working for patients. So this bill would require hospitals that participate in the program to report on the savings they receive from 340B and compare that with their costs for charity care or costs incurred for caring for Medicaid and Medicare patients and the uninsured. However, it would not provide an opportunity for hospitals to further describe the quality enhancements they are making or how they have expanded care in other ways, all of which are allowed under the original mission of the 340B program. For example, we've heard from covered entities that they use 340B savings to hire care coordination staff to help with medication management or to help patients with complex care needs get connected with specialists in social services. We've heard from some that operate additional transportation services using 340B funds or increased behavioral health services. Now, these activities all provide value and benefit for patients, but would not necessarily be captured in the reporting metrics listed in the bill. I'm concerned that if we take a limited view here, the reports produced by this legislation would imply that the program is not providing the benefits that it does, setting the program up for unfair cuts in the future. So like others, I was deeply concerned when I saw reports of a hospital in Richmond that appeared to be moving resources to higher income communities rather than in areas that needed them most. However, if this bill were enacted, it would do nothing to detect or uncover additional details or address that situation. Now, HRSA requires covered entities to attest to following all program rules annually and audits hundreds of covered entities every year for compliance with requirements under the law. This legislation would expand HRSA's responsibilities to further audit the use of covered entity savings, but includes no additional resources for the agency to conduct these audits. The current budget for HRSA's Office of Pharmacy Affairs only provides enough funding for 23 full-time staff. Additional program integrity measures will require not only more responsibilities, but more authority and resources to carry them out. The lack of resources and authority for HRSA is a known problem for the 340B program today. As I mentioned, I have long supported program integrity measures for 340B, including ensuring that drug manufacturers that participate in the Medicaid program provide 340B discounts as required by law. Over the last several years, drug companies have repeatedly refused to fill orders from 340 covered entities that use contract pharmacies, including community health centers, which rarely have pharmacies of their own. But both the Trump and Biden administrations have claimed that the drug companies are in violation of the 340B statute, but courts have found deficiencies in the agency's authority to enforce the law. So my point is, if we're going to improve program integrity in 340B, we know it will take resources and authority for HRSA to do more. Unfortunately, this legislation fails to address any of these concerns and instead may be used to draw an inaccurate narrative about the value of the program. And for these reasons, I will be voting no on the bill and encourage my colleagues to do the same. And with that, Mr. Chairman, I yield back.
Gentleman yields back. Does anyone seek recognition on the bill?
Mr. Chairman.
For what purpose does the gentleman seek recognition?
Mr. Chairman, I move to strike the last word.
Gentleman's recognized for 5 minutes.
Mr. Chairman, I want to thank you. I want to thank you for your leadership on this particular topic and for calling for transparency in the 340B program. It would help us understand how to improve the program long term, but also showcase instances where providers are using the program well that we may want to reward. Transparency is critical for this to occur. We look at transparency and you want to think, well, it's only to show where the problems are. But in this case, it can actually show us the benefit that it's having. And we can build upon that benefit. So let's, instead of looking at the glass and saying it's half empty, you can look at it and say it's half full. When the HRSA administrator was in front of this committee recently, I had a good exchange with her about two worrisome dynamics in the program. The first is around how hospitals get into the program through their nonprofit status, but provide very little charity care. We know that's happening. That's why the pharmaceutical manufacturers are balking on this. In fact, it was reported by the New York Times and the Wall Street Journal articles recently, some hospitals use it to pad their profits while depriving poor communities. Again, this is what transparency will do for us. It will show us if this is happening. This is exactly the opposite of what the program and the mission, as the ranking member just alluded to. This is exactly the opposite of what it's supposed to be doing. The second thing that it will do is it'll show how PBMs are stealing 340B discounts from community health centers and other needy providers through predatory and deceptive contracts. And they are doing that. That's what transparency is, the best disinfectant out there. I do think these issues should be looked at more closely, and I invite my colleagues on both sides of the aisle to work with me to address these urgent problems as part of a broader effort to make 340B work better for needy patients and their providers. The 340B program is an excellent program for FQHCs, for rural hospitals. It is an excellent program. That's what it was intended for. If we need to address the mission, the original definition of what this is, then we should do that. Because this is what it was intended for. But instead, it has turned out to be a boondoggle for nonprofits and for large hospital systems that it was never intended for. That's why the pharmaceutical manufacturers are so upset about this, and I don't blame them. I don't blame them one bit. And that's what transparency will do. It will help us to see where it works, what the benefits of it are for, and it will help us see where it's not working and what it's not supposed to be doing. Thank you, Mr. Chairman, and I yield back.
Will the gentleman yield?
I do yield.
Some are saying that the bill only compares the savings of 340B to how much charity care is provided by hospital, failing to account for the true value of the program. However, the bill does four things. It asks facilities to report its 340B savings for a given year. It asks the facility to report what its patient mix looks like, whether they care for individuals with Medicaid, Medicare, private insurance, or the uninsured. It asks the facility to report on how much charity care it offers. It asks the facility to report how much in payer shortfall it provides and how much discounted care does it subsidize by providing care to Medicare and Medicaid beneficiaries who reimburse at much lower rates than privately insured patients. For your average hospital, the amount of charity care and payer shortfall provided in a year will be massive values that will eclipse any savings from 340B. I would argue that for those who say that this bill doesn't capture the true value of the 340B program, being able to demonstrate that you spend more in a year on subsidizing care for low-income Americans should be an easy way to show that what this program is doing. However, if there are other metrics that we should be considering, I'm all ears. With that, I yield back to the gentleman.
And I yield.
Gentleman yields back. Does anyone else seek recognition? For what purpose does the gentlelady seek recognition?
Mr. Chairman, I seek recognition to strike the last word.
Gentlelady's recognized.
Thank you
5
very
minutes.
much. We all know that the 340B program is a vital program because it helps so many disproportionate share hospitals and safety net providers keep operating at nearly no cost to taxpayers. The program requires drug manufacturers to sell outpatient drugs at discounted prices to cover entities. And through the program, covered entities can save from 20 to 50% of the cost of drugs. That's really a whopper because drugs are expensive. And these savings are instrumental in expanding access to life-saving care for patients who are low income, uninsured, or underinsured. Now, lately, the 340B program has had controversies, including the New York Times expose of abuse of the program by Bon Secours and the actions by drug manufacturers to arbitrarily limit patients' access to 340B drug discounts through a contract pharmacy. On the heels of these controversies, this legislation attempts to bring more transparency to the program. More transparency is always good, but unfortunately, it adds significant barriers to participation in the program while not addressing, in my view, the chief causes of the concerns. The bill requires unworkable reporting elements that are difficult to disaggregate and whose definitions do not necessarily align with existing required reporting or electronic health record systems. The bill's required metrics will also unfairly benefit states that chose not to expand Medicaid by emphasizing the cost of care provided to uninsured patients. So given these unworkable requirements, Ryan White Centers and America's Essential Hospitals have raised concerns about the bill. Notably, the bill only requires transparency for one side of the program. And I think, as you noted, Mr. Chairman, that you'll work to address some of the inadequacies in the legislation. I think that this is a main one. So hopefully we can work together on this. Under the legislation, drug manufacturers are not required to report comparable data. And the bill also ignores that HRSA has already implemented several of the oversight measures to ensure the integrity of the program. And these include audits, quarterly disproportionate share hospitals' percentage integrity checks, non-governmental hospital contract reviews, and contract pharmacy integrity checks. So I support ensuring that all participants in the 340B program are fulfilling their obligations under the law. That's a must. But we can't do that through misguided transparency efforts that are burdensome and could threaten access to care. So with that, Mr. Chairman, I yield back.
Generally yields back. Does anyone seek recognition on the bill? For what purpose does the gentleman seek recognition?
Mr. Chair, I move to strike the last word.
Gentleman's recognized.
Thank you, Mr. Chairman. Let me be clear. The legislation before us today is not an attack on the 340B program, but rather it is necessary transparency legislation. I applaud you, Dr. Bouchon, for raising awareness on the need for greater transparency and greater accountability. As doctors, we are both trained to arrive at the right diagnosis before we can make a treatment condition for any condition. If Congress is going to address the rising cost of healthcare, we need to make sure that we understand all the incentives that are contributing to these high costs. One of the biggest drivers in increasing spending and consolidation over the past decade has been the 340B drug pricing program. Without greater transparency into where the money is going or what those profits are going towards, we can't begin to address this program and to ascertain whether these funds are being spent correctly. So I support this first step in ensuring greater transparency to protect the 340B program. I recognize the essential nature of the 340B program for the rural hospitals in my district in Pennsylvania. This legislation is simply a way for Congress to have a better understanding on how these dollars are being used and if they are indeed a driver to higher costs. I urge all of my colleagues to support this bill, and I yield the balance of my time.
Will the gentleman yield?
Yes.
Today we're focusing on transparency, and some people have brought up the pharma cutting 340B rebates from contract pharmacies and undermining the program. I think we need to get to the bottom of the contract pharmacy issue, but the only way to do that is have the courts settle this issue once and for all. If the hospitals are right and pharma is acting illegally, the courts will say so. However, I believe that actually addresses or changes the scope and the size of the 340B program. Anything that does needs to be a subject of a broader conversation on reforms to the program and needs to move through regular order. If my colleagues want to discuss contract pharmacies and other reform topics, I'll gladly join in. I believe the Energy and Commerce Committee is the only committee in Congress that could ever solve a problem like 340B because we have such a rich history of bipartisanship and cooperation, and if we want to do this, I think we can absolutely get this done in a bipartisan way. I yield back to Mr. Joyce.
I yield the balance of my time.
Gentleman yields back. Does anyone seek recognition on the bill? For what purpose does the gentlelady, for what purpose does the gentlelady, Ms. Custer, seek recognition? Gentlelady is recognized. 5 minutes.
Thank you, Mr. Chairman. I move to strike the last word. The 340B drug discount plays an essential role in the delivery of care, particularly in rural areas and to vulnerable populations. In my district, healthcare providers rely upon 340B to stretch scarce resources and continue to serve as the healthcare safety net for many rural communities. This bill would distract from the true purpose of 340B, which is to support patient care. I will continue to defend the 340B program, and I urge my colleagues to do the same, and I yield back.
Gentlelady yields back. Does anyone seek recognition on the bill? For what purpose does the gentlelady, Ms. Craig, seek recognition?
Thank you so much, Mr. Chairman. I move to strike the last word.
Gentlelady is recognized. 5 minutes.
Thank you, Mr. Chairman. I'll be brief. I'd just like to express my opposition to this bill. Let me start by saying that no one here is opposed to the concept of transparency, more transparency in healthcare. Frankly, in a country where a kidney transplant can set you back the cost of a mortgage, it shouldn't be a given that patients and consumers can access the data that they need to make informed choices about their care. But those transparency requirements, to give us that data, we need it to be requirements, data that we can actually use. The reporting requirements outlined in this bill would place unnecessary burdens on the 340B entities like Minnesota Valley Health Center, Mayo Clinic Health System in New Prague, and would do little to provide insight into how 340B savings are used to get resources to patients. We need to make it easier for hospitals and healthcare providers to manage rising prescription drug costs, not weaken the very program that's helping them. This bill places burdensome new reporting requirements on hospitals and could make it easier for bad actors to tear down the 340B program. Let's take a moment to remember that these are our safety net hospitals that we're talking about. They serve the most vulnerable people in our country. Low-income communities rely on their services, and the 340B program was designed to ensure that they can keep their doors open. Heaping an onerous, confusing reporting requirement does nothing to improve the quality of care that these entities provide. It's my hope that we can come together on this issue to strengthen the integrity of the 340B program and to do so in a bipartisan manner. Thank you, Mr. Chair, and I yield back.
Gentlelady yields back. I ask unanimous consent to insert in the record the documents included on the staff markup documents list. Without objection, that will be so ordered. Are there any amendments to the bill? Seeing none, the question now occurs on forwarding H.R. 3290 to the full committee, and a roll call vote is requested. The clerk will call the roll.
Chair Guthrie. Chair Guthrie votes aye. Mr. Burgess. Mr. Burgess votes aye. Mr. Latta. Mr. Latta votes aye. Mr. Griffith. Mr. Griffith votes aye. Mr. Bilirakis. Mr. Johnson. Mr. Bouchon.
Aye.
Mr. Bouchon votes aye. Mr. Hudson. Mr. Carter. Mr. Dunn. Mr. Carter votes aye. Mr. Dunn. Mr. Dunn votes aye. Mr. Pence. Mr. Pence votes aye. Mr. Crenshaw. Mr. Crenshaw votes aye. Mr. Joyce. Mr. Joyce votes aye. Ms. Harshbarger. Ms. Harshbarger votes aye. Ms. Miller-Meeks. Ms. Miller-Meeks votes aye. Mr. Obernolte. Mr. Obernolte votes aye. Chair Rodgers. Chair Rodgers votes aye. Ms. Eshoo. Ms. Eshoo votes no. Mr. Sarbanes. Mr. Sarbanes votes no. Mr. Cardenas. Mr. Cardenas. Mr. Cardenas votes no. Mr. Ruiz. Mr. Ruiz votes no. Ms. Dingle. Ms. Custer. Ms. Custer votes no. Ms. Kelly. Ms. Kelly votes no. Ms. Badagan. Ms. Badagan votes no. Ms. Blunt-Rochester. Ms. Blunt-Rochester votes no. Ms. Craig. Ms. Craig votes no. Ms. Schreier. Ms. Schreier votes no. Ms. Trahan. Mr. Hand votes no. Mr. Pallone? Mr. Pallone? Mr. Pallone votes no.
Are there other members seeking recognition? How's Mr. Bilirakis recorded?
Mr. Bilirakis is not recorded.
How's Mr. Johnson recorded?
Mr. Bilirakis votes aye. Mr. Johnson is not recorded. Mr. Johnson votes aye.
Anyone else seeking recognition to vote? Seeing none, the clerk will report the result.
Vice Chair Bouchon, on that vote, we have 16 ayes and 12 nays.
The ayes have it, the bill is agreed to. Without objection, staff is agreed to and forward to the full committee. Without objection, staff is authorized to make technical and conforming changes to the legislation approved by the subcommittee today. So ordered. Without objection, the subcommittee stands adjourned.